Hello, everyone. Welcome to Ask the Pediatrician page, and it's our online conference. This is our annual anniversary week. Ask the Pediatrician is 3. And as part of our anniversary week, we are having our annual online conference. And this year, our theme is about pediatric emergencies, the roles of parents in reducing child deaths. And we have going to have it for 2 days, and today is day 1. And we're very excited. Today we're going to have 3 speakers talking about different aspects of pediatric emergencies. And already I have with me in the studio our renowned consultant pediatric surgeon, Dr. Idika, who is going to be giving us an overview about pediatric surgical emergencies. And so I'm inviting all of you to join us right now. If you can kindly share the video so that your friends can join us. For the first 30 minutes, we will speak. Dr. Oge will be talking to us. And after that, you can drop your questions as comments, and then we will be able to take them and we'll be able to feature them. So kindly invite your friends. But just kindly note for those of you who are watching as watch party on Active Pediatricians group that you have to navigate to the page so that we can see your question, because that is the only place where we'll be able to feature questions. And so thank you so much for joining us, and I hope you will have a nice time. I am Dr. Gbemisola Boyede. I will be anchoring the program today, and it's a pleasure to have with me today Dr. Oge Idika, and she will be speaking to us about pediatric surgical emergencies. Dr. Oge, you are welcome to Ask Pediatricians Live. It's a pleasure to have you here with us today.
Okay. Thank you very much, Dr. Gbemisola. Thank you very much, Dr. Gbemi. And it's a pleasure to be here to discuss pediatric surgical emergencies with all our viewers. I think so that we make the most of the time we're going to spend. I think we won't dwell so much on the introductions anymore. So I think I'll just go straight to the discussion at hand. Meanwhile, my topic has been made pretty simple by Dr. Gbemi, because yesterday, for those that tuned in yesterday, she did a thorough job of discussing pediatric emergencies. So there were some basic things that would apply also in pediatric surgical emergencies. So by way of introduction, like she said, what exactly are pediatric surgical emergencies? So if we look at the slide that has what pediatric surgical emergencies are. Yesterday, like Dr. Gbemi said yesterday, an emergency is not something that you can stay and wait and ask questions about. But like she said, once one is able to recognize what an emergency is, that would help to decide on time what to do to prevent these things from, becoming serious conditions that there's nothing you can do about it, and so that it doesn't become too late. So what a surgical emergency essentially means any condition that would require surgery as part of the treatment or the whole of the treatment for. It's a condition that it cannot be treated successfully without the child having an operation, either a minor operation, a major operation. Anything that requires an operation as part of the treatment would qualify as a surgical condition. And when it's an emergency, an immediate, urgent surgical intervention will be required for treatment. So essentially, that's the definition of surgical emergencies. Now, having said that, it's important to know that it's not every pediatric surgical condition that would qualify as an emergency. So what we're going to be looking at essentially is what are the things we need to look out for? What are the things that we will see that will make us say, okay, this looks like it's an emergency and it may need to have surgery as part of its treatment. Before I go on, I would like to highlight the fact that it's always important to detect any of these conditions early. Just like in pediatric medical conditions, if these conditions are recognized early, it would help us to intervene on time, and that would improve the outcomes for these children when they get into these kind of conditions. So early recognition, early detection, it would contribute to early presentation. And that is one of the things that we need to get across, that we need to do something as soon as possible. So once we recognize that, it would guide how well we'll be able to provide treatment for the child, and it will improve. It will go a long way to improve the outcomes of these children that have surgical emergencies. Now, going on, before I delve in straight to the symptoms or the things that we need to look out for to say, oh yes, this looks like it's an emergency, and I think my child may need an operation. I think it's important for us to know that these things can happen. When we say the pediatric age group, I'm sure along the line, Dr. Gbemi must have, defined what we mean by the pediatric age group. So that newborn babies, babies that are more than a month old upwards to 1 year, that's newborns, infants, preschool age, and school age children. All these people up to early teenage period. These are all fall into the pediatric group. And it's important to note that surgical conditions can occur in any of these age groups. And surgical emergencies can also occur across this broad classification of the pediatric age group. So having said that, I think I can go on to the things that we need to look out for. Okay, I'll try and keep this discussion as simple and short as possible so we have enough time to entertain questions.
Thank you,
Okay,
Dr.
so yeah, thank you. So if we can have the slide up on what to look out for. We have just a couple of symptoms listed exactly. So from there, we can see, I've tried to make out a very simple list of things that we can look out for. And if we're looking at that, if we can see that slide clearly, we can see that there are certain things that have been mentioned as pediatric emergencies, and we're seeing them showing up again here as things that we can look out for as pediatric surgical emergencies. Usually there is some degree of overlap in the kind of things you will see. And it's always advantageous to be able to get the child to see, even if a child sees a pediatrician, the pediatrician will always be in a very good position to be able to say, oh, this would require the intervention of a surgeon. Now in the list, we have on the list written fever there. Okay, I'm not going to dwell on fever. Dr. Gbemi has done an extensively good work on fever. So when a child's temperature is going very, very high, apart from the initial care that she has already described in terms of giving paracetamol, episponging the baby, the next line of action, if the fever is not abating, will be to take the child to the hospital. We even see it in the adverts of the paracetamol. They'll tell you if the symptoms persist after a certain number of days. Sometimes we don't have to wait for that long. If the fever is high grade, it's persistent, we need to take the child to the hospital as soon as possible. Now, I've written vomiting here. It's good to know that it's not every vomiting that means a child has a pediatric surgery emergency, okay? But it's important to know that there are certain things you will see in vomiting that will make you suspect that this child has a pediatric surgery emergency. For example, a newborn baby. A baby is born. It's not every child that is opportune or eventually is born in maybe a teaching hospital where you have different specialist units on ground available to review the child at every point in time. So it's important to take note that if a baby is born, a newborn, even if you've been sent home and then you notice that this baby, within the first few days of life, within the first 1 week of life, the baby is vomiting. Okay, the baby feeds and then vomits. And the thing about the vomiting is usually if that vomiting is greenish in color, if what the child is vomiting is not just the breast milk coming up, some people may mistake vomiting, mistake regurgitation as vomiting. If a baby is not belched properly and is put to lie down, sometimes the milk may just trickle out of the mouth and all that. That would not qualify as vomiting. But if a baby has barely even fed within the first few weeks of life, first few days to the first week of life, and the baby is vomiting and the vomiting is greenish, okay, those are some of the things. That's one of the things that raise your, you have to, take a second look and say, look, this is becoming suspicious. Okay, if it happens once, you observe it happens 2 times, 3 times, that child is likely to have some form of a pediatric surgical condition and most likely would need some form of emergency intervention. Okay, I'm not here to start telling us the different things or the different conditions that may lead to this, but just to let us know that if these are little things that we notice and then we'll say, okay, I need to start taking this child back to the hospital. Okay, so I've mentioned vomiting. If the vomiting also comes out and is forceful, okay, if a child is about 3 weeks, 4 weeks, about a month, 6 weeks old, he feeds. After feeding, within a few minutes, the baby, vomits forcefully. Okay, the vomit just comes out with a lot of force. Okay, in such conditions, it may not be green. In that kind of condition too, the patient may have a surgical emergency and the baby needs to get to the hospital as soon as possible. And the thing about vomiting is, if it goes on for quite a while and the baby does not present on time, of course, dehydration begins to set in. Okay, we talk about dehydration. If we notice the child is vomiting, we attempt to, the child is stooling or vomiting, and you attempt to give the ORS and the child is not tolerating it, then you begin to think about there may be a condition, there may be a reason why the child is not tolerating those fluids, the child is not tolerating fluids, and then we have to start thinking about getting the child to the hospital as soon as possible. Okay, and then let me just go back a little bit. When I mentioned that this can happen in units, it's important to know that when a child is born, when there's a newborn baby, it's very important, if you have the opportunity, to let the doctors or the nurses or any medical personnel that is present at the time when that child is born to do a thorough baby checkup, to examine the baby completely. Because that can help us to detect. Yes. Usually sometimes some people, you have a normal delivery, or we're grateful and everybody's in a hurry to get home. You're entitled to have that. Okay, you ask the medical personnel, please help me to examine my baby very well and see if there's anything that's that may be missing. Because I'm saying this because there are some pediatric surgical emergencies that if the baby is examined very well, soon after birth, we may be able to detect it even without the baby beginning to show overt symptoms of an illness. For example, if you have to check, is the anus open? Has the child passed stool? If the baby has not passed that first black poo-poo within the first 24, 48 hours, within the first 2 days of birth, okay, we begin to suspect that there's something going on. Yes, we need to suspect there's something going on, all right? And if it's not detected on time, it will just progress. The baby will start vomiting with time. The baby will start to have abdominal distension. The tummy begins to swell, okay? And that would suggest some kind of condition that may have been there right from when the baby was in the womb. So a thorough examination of the baby when the baby is born is very important. I've only highlighted one thing, which is if the child does not pass that stool first, it may be that the anus is there, but a part of the colon, the part of the intestine leading to the anus that carries stool may not be working properly. And because of that, the stool will not come within the first 2 days of life. Later, the baby may pass stool and then gradually begins to have infrequent passage of stools. Okay, the baby now has a constipated pass and begins to pass stool not as frequently as described as what we know for babies that are breastfed, normal newborn babies that pass stool maybe up to several times in a day. Such babies may not pass stool every other day. So knowing that the baby has passed that first black stool when it's born is very important. Again, sometimes some babies will pass that stool, and then one is not careful to check where exactly did the stool come out from. Okay, because some children are born without an anus. They don't have an anal opening. Okay, and the stool will find its way out from another place. So the child may have stool in the diapers, but it's not coming out from the right place. So it's also very important. That's why. Yeah, so we need to, it's always good to get medical personnel to really thoroughly examine the baby and be sure that everything is in place. Okay, so I just felt I should highlight that. Another important thing is before the baby leaves the hospital too. Some babies say, oh, they attempted to feed the baby at the hospital and the baby is not tolerating feeds. And all you see is saliva is pouring out. Saliva is just pouring out of the mouth of the baby every time. Okay, when we see something like that, if you observe in your baby that, okay, you've had the baby for one reason or the other, you've gone home and you're attempting to feed, every time the child is always drooling. And I'm talking about a newborn baby, okay? Newborn baby, we need to take that child back to the hospital as soon as possible because it shows that there is a problem that is not allowing the child to swallow. It's not allowing the child to handle is saliva by itself. So it's very important so that we don't miss these things. Because in a condition like that where the baby is not able to swallow, within a short time, the saliva, overflows and gets into the airways. Okay? When it gets into the airways, the child comes down with a lot of chest infections, and that will complicate the treatment of the baby. Even if the baby is going to have surgery later, it's going to complicate the treatment. But I understand when Dr. Renner comes, we'll talk more about aspiration.
Aspiration, yes, we are going to have that.
Yeah, so he's going to talk more extensively about aspiration. So I'll just move on. So I just try to emphasize the importance of having a thorough check of the baby before you leave the hospital. Exactly. And then also, yes. So try and get your baby checked. And then jaundice, if the baby has yellowness of the eyes, okay, sometimes it may not be considered a surgical emergency, but it's not every jaundice that a baby has that will resolve by, there are some causes of jaundice that a baby will need to have an operation for.
Yes.
Okay, so that again emphasizes why we should try and get the baby fully examined. That's the advantage of when we say, oh, go to teaching hospital. We are not against every other hospital, or get to a hospital where you have specialists available, okay, to examine your child. So that would go a long way, because in those kind of conditions where a child will need an operation to solve that jaundice problem, you usually have a very narrow window within which this can be done. And that can be the difference between having to change a baby's liver or the baby surviving. So the important thing is also for jaundice babies, they need to be thoroughly examined. So we are sure that the baby does not have what is called a surgical jaundice, a jaundice that would need an operation to help to solve it. Okay. So I think I've kind of veered off. So
no
I'll
problem,
try and get back to this.
Do you want me to show any of your other slides and go down?
Okay, yes, we can just still look at the slide of things to look out for, because I think we just touched on fever and vomiting. Okay, we've also talked about constipation to some extent. The third item on that slide is, please, can you help me to read out the third item on the slide?
Irreducible ground swelling.
Okay, yes. That is another very yes. So that's another very important thing to look out for. Now, beyond, sometimes when the baby is really still newborn within the first 28 days of life, sometimes beyond that period, it may not be very obvious when the baby is just born, when the baby is really small. But we should look out for a swelling around the genitals, a swelling around the groin. Okay, if the baby has a swelling, and this swelling tends to be more obvious when the baby cries or when the baby coughs, okay, or if the baby has any reason to be straining, struggling to pass stool out. If that swelling becomes more obvious, it's always good to take note that, oh, this swelling is there. And then one should know that, in fact, we've discussed hernias at one of our parent ground rounds in the past on ATP. So I think if we can go back to our lectures on hernias, yes, that's where I'm driving at. That swelling in the groin is most likely a hernia. Okay. When we notice that the baby has a hernia, there are things we tell the mothers of such babies. On a good day, the swelling will come out. The baby cries. The swelling comes out. It goes back on its own. We're not worried. Okay. But the important thing to note is that sometimes that swelling will come out, and it will not go back inside. Okay. When a swelling that you notice, if a mother notices a swelling has been around the genitals, around the groin, around the private part of the patient, okay, if that swelling has been coming out and going back, once you notice that the swelling has come out and it has refused to go back, and the child is irritable, the child is crying, occasionally it gets so bad, the child begins to vomit, the child is not able to pass stool, please, such a baby must be taken to the hospital, must be taken to the nearest children's emergency as soon as possible. Okay, it means that hernia has become complicated. Dr. Gbemi, I've experienced a particular case in which the child came and it was already far, the emergency had gone for long. Why? She was told by someone that when that swelling comes out, give the child paracetamol. Now, that is not what to do.
No.
Okay, that is not what to do. So when we notice that the groin swelling, okay, once you notice the groin swelling, it's there, it comes out, it goes back in. But the day you notice it has come out, it has remained out, please take the child to the nearest children's emergency, okay, that you can find. Why are we bothered? There are two things that we're bothered about, okay? The testis of the baby. The testis of the baby is there, and the blood supply for children is so small. So we just need a few hours, and after a while, the testis on that side, okay, may be affected, and it may cause the child problems later. Okay, when the child may have issues with fertility when he has grown up and is a man, he may have, those are things that we're concerned about. So that's why we say once you notice a growing swelling, it has been there, but now it has come out, it's not going back in, bring the child to the emergency room. The second thing we're bothered about is what entered there is a part of the intestine. Okay. Now, if we don't bring the child on time, the intestine just gets squeezed. After some time, the blood supply will be affected. After some time, that intestine will not work properly. That part that is trapped, it will not work properly, and would need an operation to, make sure that they were able to sort it out. But if you present on time, if you're able to take the child on time, if you recognize these things, the swelling comes out, it's not going back. The baby is irritable, you touch that area, you touch that swelling, and the baby is crying. That area begins to look reddish, it begins to look like it is warm, you feel it and it's warm. We don't even have to wait till it gets warm. The moment you notice that's growing swelling you've been noticing before, it doesn't go back inside. Please and please take the child to the nearest hospital, to the nearest hospital, so that immediate care can be offered. For some, you may escape without having an operation that night if we're able to present. But others, you may not, be that fortunate. So it's important for us to take note and not overlook such things. Okay. And then those things are not things you postpone till the child is much older. Now that I'm talking about hernias, let me quickly talk about a child that's, when the baby is examined too, especially for male children, we need to check and see if the two testes are down, are inside the scrotum. So if we notice at the time, that's why I keep emphasizing a thorough examination of the baby before leaving the hospital. If it is noticed, usually you'll be told, oh, you can come back and see us, so they can monitor and see if it will still come down, especially for those that are born premature or preterm babies. We have to watch and see if the testes will still come down over time, or it needs to be, brought down by surgery. Okay. So the important thing is check. If the testis is not down, please, the oldest a child should get without the testis in the scrotum, for now, we will say 1 year. If by the child is approaching, once it's 6 months, getting to 10 months, 11 months, 1 year, and the testis has not come down into the scrotum, one of the balls in the testis, if it's not inside the scrotum, please bring the child to the hospital. Okay? Because occasionally we come across parents that noticed it and they were misinformed that, wait until the child is 5 years, or wait until the child is 9 years old, or wait until the child is 12. And then you find, young boys who, so for some that is two sides that are affected, you have practically almost reduced the child's ability to be able to father a child. It's not absolute. There are other things that can happen, but these are things that we can avoid. So as much as possible, if you notice that one testis is not down within the first 6 months upwards, once it is noticed, please let the child be seen by a pediatric surgeon. I would classify that almost like an emergency, because the effect is far-reaching. It will affect the quality of life of that child in the long run. Okay, so that's an irreducible growing swelling. The next point after that is
bloody mucous stool. Passage of mucous stool.
Okay, yeah. I would really like to, I'll kind of not really dwell on that, but I don't really need to dwell on that, because there was a discussion on diarrheal diseases. For those that missed,
and we talk about dysentery and all that.
Yes, on over the weekend, I think. To do well to go back and watch that and be able to identify diarrheal diseases. What exactly we mean by diarrheal diseases? Okay, like what Dr. Gbemi said, it's when you have watery stools, it takes the shape of the container, it's frequent. Okay, the important thing to note, she also talked about dysentery in that when that discussion went on. Now, for a surgical emergency, once you see a baby passing blood-stained stool, Okay, whether it's dysentery or whatever, it's always safe to come to the hospital. Okay, it's extremely important to bring that baby to the hospital. Why am I talking about bloody stools under pediatric surgical emergencies? It's one of the signs, the symptoms, one of the things you will see usually in infants. Those are usually between 3 months to 9 months, 10 months. Usually when they get around the time of being weaned, they can come down with a condition, a surgical condition known as intussusception. So it's not every bloody stool that is just simple dysentery.
Dysentery or diarrhea, yes.
Yes, it's not every bloody stool that is a simple dysentery and diarrhea. So it's not something you stay at home and say, okay, let me just give antibiotics, let me do this. Please do not self-medicate. Bring the child to the hospital, because when the child comes to the hospital, that one will be able to tell the difference that, oh, this particular blood in stool is indicating that the baby has a cause of intestinal obstruction. And if it is not addressed, the intestines may need to be, cut off if it doesn't survive at the end of the day. Okay, so it's really important that if a child has bloody mucus stools, in addition to vomiting, and then the tummy is swelling. Okay, those are things that you see in a baby that has intussusception. And occasionally, because they are young, they cannot say, "Oh, my tummy is paining me." For the infants, for those ones that are, not yet speaking, and this is a very common condition in that age group. Because they can't say, oh, my tummy is paining me. What happens is that you will notice the child is, usually is an otherwise healthy child, is nice and chubby, and happy. And then after a while, the baby begins to, have this bout of, as if he has colic. Okay, the baby now feels uncomfortable, cries, uncontrollably cries, twists the body up and down. More often than not, they tend to fold their legs upwards and they cry in pain. After some time, they relax. Okay, so those are some of the things you look for. The baby is crying, is fed, and after some time, he's crying, wriggling, raising the legs up in pain, and after a while, he relaxes. Okay, and we notice that then after a while, the baby begins to vomit, and then the stools. Okay, first of all, usually they present as though it's just a diarrhea. It starts like frequent watery stools, and gradually becomes blood stained. Okay, so those are some of the things we look out for. The baby starts having abdominal discomfort, is vomiting, passes bloody mucus stools. Please do not wait. Okay. For that particular condition, the longer you wait, the worse the condition becomes. So the earlier it is picked, sometimes if you come early enough in the symptoms, the child may be able to have other measures done, not necessarily surgery, to be able to reduce it. Okay? So it's always better to present on time. Okay, moving on to our second list of what to look out for. If you can help me to bring that up, Dr.
Okay, I think that's yes. Constipation, abdomen.
Okay, yeah.
I think you've talked about constipation already. Abdominal pain.
Yes, I've talked about. Yes, I've mentioned that already. Abdominal pain. Yes.
Abdominal.
Usually for abdominal pain. Aha. So those two tend to go together. Abdominal pain, yes. Abdominal distension. Yes. Yeah, so for those that are old enough to talk to you, they will tell you, oh, my tummy is paining me. Of course, but we know there are there's so many things that can cause pain in abdominal pain in a child. Yeah. But if a child keeps complaining, oh, this thing is paining me, and then you notice that the child is vomiting, or you notice that the tummy is beginning to get bigger, okay? Or you notice that the child is not going to the toilet as often as he used to go. Okay. All right. And he's complaining about this abdominal pain. Please, let's not take it lightly. It may be a surgical abdomen. What we call is a surgical abdomen, and that child needs to be seen by a doctor. That's why I'm very glad that, as the pediatricians, once a child is able to see a pediatrician will be in the best place to even say, oh, look, this looks surgical. Let us call the pediatric surgeons on board. So the sooner you get to a children's emergency, the better the outcome of the child. Okay, what else do I have? I have the difficulty passing urine.
Yes.
Okay? Difficulty passing urine. Yeah. So for some children, there are some conditions, surgical conditions that will make it difficult for a child to pass urine. If a child having difficulty passing urine is crying to pass urine or is passing blood in the urine, those are things that you don't wait for. I'm sure for blood coming out of the urine, I mean, you usually don't have to tell mothers about that one. They naturally,
they panic.
Bring the child they run. Yeah, they panic, and when they see blood, they come.
No, some moms will come and ask us on ATP.
So those ones, once you see things like that, please don't wait. Start bringing the child to the hospital. Another thing to note, I found out that for some, when the babies are still in diapers, okay, we may miss the difficulty in passing urine because we are not able to observe how well the urine is coming. So for those, neonates, newborns, infants, those that are still in diapers, mothers should use the opportunity when the baby is having a shower, a morning bath. Okay, usually when you open the diaper, they have this tendency they want to pee. So when they pee, please look at the urine, the way it's coming out. Is it coming out freely, especially for male children? For male children, is the urine coming out, the way that urine will flow, just come out smoothly. For a child, we should check that. If a baby's urine is dripping, just dots, drop by drop, there is something going on that needs to be investigated and may be amenable, may be treatable by surgery. Okay, so that's why I included difficulty passing urine. I'll soon finish with them. There's not much left to discuss, so we can entertain questions.
Yes, yes.
The next item there is, Dr. Bemi, can you help me with that?
Yes,
the last item on that.
The inability to walk or move a limb after a fall. Inability to walk or
I've
move
included,
a limb.
Yeah. Okay, I've included that because when we say pediatrics,
yeah,
exactly, yes. I've included that because I don't want us to be carried away that, all pediatric surgical emergencies are related to the abdomen or related to passing urine. Pediatric surgical emergencies include trauma, okay? A child falls down, like Dr. Bemi was saying, a child falls down in the loss of consciousness. That's why I don't want to dwell there. But if you notice that a child has fallen down, sometimes, children, they just get up and try and move all over again. But if a child falls down, he's not able to get up again, or is not able to move a limb. It's not the time to say you're trying to put it into place or you're trying to do one thing or the other. Please, as much as possible, take the child to the hospital. The least you can do in terms of first aid is, okay, try and splint it. Splint it means just get a firm support for that limb. Don't tie like what some people do. They would come and tie something very tight. No, don't tie something tight on the leg or the hand of a child. Because we're not just concerned about the bone, we're concerned about the blood supply to that leg, to that hand. So don't tie tight things, okay, on the legs or the hands of a child. You feel the child fell down and you're trying to give first aid. Just find a gentle support like a cardboard and place it just under the limb as a form of support and just hold it gently. Don't tie it tight over the limb. That's the least you can do, and then you can, present at the hospital. Of course, we wouldn't need to talk about accidents that happen on the road, or if a child is hit. Those ones, we don't need any, normally, naturally, we just take the child to the hospital. So I just try to make it simple, make it like an overview to touch on, what you see. And then the things that you need to do. My last slide says what to do. Like Dr. Bemi said, very important, do not panic. When you see those things, do not panic. Call for help. Like she said, call for help. Call for help from neighbors, call for help from friends, okay? Do that. And then the first aid you're able to give, if it's a cut, like she said, apply pressure. I don't need to go over all that. I deliberately did not talk about burns because Dr. Bemi had already done justice to that yesterday for the initial care. People are concerned about, okay, so what do I do while I'm waiting to go to the hospital? You already mentioned, just, apply run cold water over it. Okay, and then if it's not a serious burn, you can apply them as in cream. But once the basic things are done, do not apply eggs, do not, put any of those funny things that people tend to put on wounds. Okay, so that's why I deliberately did not really talk about burns. So I think I've essentially tried to keep it very short and simple so that I can take any questions. Probably we'll be able to touch on more things as the questions come along.
Okay. Yeah, thank you so much, Dr. Oge. So viewers, you've been listening to Dr. Oge, and that's our consultant pediatric surgeon, and she's been basically telling us what to watch out for when things that children may present with that may suggest pediatric surgical emergencies. And like we've been emphasizing, The issue here is that you really need to go to the hospital on time, because emergency is something that there must be intervention immediately. It is not something you got to wait. You have to go. And Dr. Oge has highlighted that. And if you are just joining us, so this is a point where Dr. Oge will take your questions. Please, I know many of us are watching on different platforms. Some of us are watching on Ask the Pediatrician Foundation page, and some of us are watching as a watch party on Ask the Pediatrician Facebook group. For those on the group, we will not be able to see your questions, so you have to come to the page if you have a question. If you don't have a question, that is fine. You can just keep watching on the group. But if you have a question, comment, anything you want to tell us, kindly click on Ask the Pediatrician page itself and go to the live video on the page, drop your questions there, and we'll be able to take it. And right now, Dr. Ogesi has about 20 minutes with us in the studio, and so she can take our question. So what I've been seeing basically is just people commending the show, and they are really enjoying it. But we want to take your question as well. So if you have question, kindly help us to post your question now, and so that we can take your questions. This is the time to ask a question, because once Dr. Oge has gone, please don't come and drop your question in comments. We will not be able to answer it. So because we are going to have Dr. Another one of our doctors already, who is going to talk to us about the emergencies in the newborn period. She's already waiting. But while we're waiting for your question, I'm going to ask Dr. Oge a very simple question. Dr. Oge, can you operate on a newborn baby? Because mothers ask a question like that a lot, that newborn babies are too small for operation care.
Yes.
How can you operate on a newborn baby? Dr. Oge, please tell us what you do. Can a day-old baby be operated on, basically?
Okay. Yeah, Dr. Baby, thank you for bringing up that question. I've always looked for the opportunity to be able to, talk about that. A newborn baby can be operated on. As a matter of fact, in certain parts of the world, babies inside the womb can be operated on. Okay.
Oh,
but what
really?
obtains?
Are you serious?
Yes, so that fetal surgery is something that is ongoing, especially in the developed countries in the Western world. But what obtains mainly in developing countries, we do have the ability, we can operate on newborn babies. Why? Because there are pediatric surgery conditions that are called congenital conditions. Some babies are born with an abnormality, and the moment they are born, you need to fix it. And that brings me to something I kind of left out. There are some babies that are born with a defect. What means that the tummy, the front wall of the tummy did not close properly.
You've talked to us about it before on the group, on fallacy or gastritis.
Exactly. So those ones also qualify as pediatric emergency. Once you notice that, and you notice anything abnormal in the tummy of the baby that is outside, that should be inside, that baby should be in the hospital. And babies that are newborn, we can operate on babies on the first day of life. Yes, we can. Provided, that's why it's good to go to teaching hospitals where we have anesthesia teams, doctors that are trained to put little babies like that. Even preterm babies, the ones that are not up to 2 kg, less than 1 kg, we can operate on that. Provided you go to a standard center where they are trained anesthetists that are able to put the baby to sleep for the operation. So a newborn baby, on the first day of life, a baby cannot be operated on. Yes. So the babies are actually safe. So it's always be in the right place. Go to a proper teaching hospital where a hospital that has specialist coverage where such operations can be done. So yes, babies that are newborn can have operations. All that is required is to make sure that everything is as it should be. They are not way too small for us to operate on. That's what pediatric surgeons do. Yeah.
People always think that when you have, because those are the things that scare them from coming to the hospital. And when people hear the word operation in these parts of the world, they are so scared. And they think, oh, that's the worst thing that can happen. So Dr. Oge is telling us that newborn babies can be operated if necessary. In fact, a baby in the womb can be operated. So thank you, Dr. Oge, for that clarification. So I have a question here by Ebere Favor. And Ebere Favor is asking that, is it possible to deliver a baby at 6 months and baby born in 6 months, can it survive? Okay, so just for our viewers, when you're asking questions, we plead with you to ask questions that are related to what we're talking about right now. I know we have so many questions, but this section, Dr. Oge is a pediatric surgeon, and she is going to be talking. She has talked to us about overview of pediatric emergencies, what symptoms, what signs you will see in a baby that may suggest a surgical condition that requires that that baby needs to be taken to the emergency room and a surgeon needs to operate on that baby. So we will appreciate if you keep your questions focused, on the right topic. We are not talking about prematurity, but since I'm here and I'm a pediatrician, and
Yes.
I will just quickly, I will just quickly
Yes,
answer
we
that.
proceed to that.
So
Yeah.
basically, a baby can be delivered at 6 months. We will not deliberately deliver a baby at 6 months anyway. It means that
Yeah.
baby came out for whatever reason, premature delivery, something was going on. But we usually, and the survival of that baby depends on the weight of the baby and depends. So we've had babies as early as 22 weeks surviving. Well, we've had babies as
Mm.
early as I'm not sure of the current figure now, but I think it's between 20 and 22 weeks. And that is just 5 months old. So in other words, so baby at 6 months can survive. But of course, survival rate is better the longer
Yeah.
the age, I mean the months the baby stay in the womb and the higher the weight of the baby. But we've had babies below 500 grams surviving, but they can also be prone to a lot of difficulties and challenges in
Yeah.
future. So it can happen. So thank you so much, Ebere, for asking your question. So, but basically, what we're saying now is that. Sorry, I went off. So, what we're saying is
Hello.
that please ask your questions. Dr. Oge, I'm back. Ask your question
Yeah, good.
about the question that Dr. Oge is okay. Okay, I can see more questions coming in.
Okay.
Uju is asking, I want to know if there's any side effect to taking vaccine for prevention of. Uju, you're not saying sorry, I debated. So please, again, ask us questions on surgical emergencies. We don't want to take questions on the. There are vaccines. Every vaccine has side effects, but
Yeah.
the benefit of vaccines outweigh the risks and the side effects. Okay, so
Mm.
Oyeko Omolara is asking, please, ma, I don't hear well what we can apply on buns instead of raw eggs. So Dr. Oge,
Oh,
he said,
okay.
what first aid can we apply on buns? Of course, bun is also one of the surgical
Yeah.
emergencies, even though it's not
Yes.
pediatric surgical, but I'm sure Dr. Oge can give us insight on that. Thank you, Oyeko, for asking.
Okay.
Yes, so Dr.
Okay.
Oge.
Okay. Okay, in response to Oyekon's question, I was just making reference to your presentation yesterday, Dr. Bemi,
I
when you
know,
said, and
yeah.
which rightly said, that the first thing you can do to apply is on burns is cold water, okay, or like
Okay.
room temperature water. Just run water over the burnt area, okay, and
Okay.
then start taking the child to the hospital depending on the size, the depth of the burns. And since we're not all in a position to be able to decide, oh, this is a large burn or this is a small burn, to be on the safe side, just apply water. Or if it's not just a small area, very tiny area, maybe on the hand, you can apply dermazine cream. So those are the things, the
Okay.
two things that were mentioned yesterday. So those are the basic things you can do, and then bring the child to the hospital. Okay, when the child
Okay.
gets to the hospital, every other thing can be done. Yes. Like she said, those things we apply, the raw egg and every other thing, they
You
infect, they
and all
contaminate
those
that burn.
they actually
Yes.
wasn't the thing. Okay, so Doctor,
Yes.
okay, yeah. While people are waiting to ask the questions, is it possible? Is there any first aid for surgical emergencies? Because sometimes mother will ask us, I'm living in the village, oh, and there's no teaching
Yeah.
hospital here. Oh. So what can I do before I go to the hospital? So I don't know what will you like to say to that? For those who say I'm living
Wow.
so far away from the teaching hospital. There's no pediatric surgeons. So, what will you want to say to that?
Oh wow, that is kind of it's kind of a tricky one because it
Yeah, I
depends on the
know.
kind of emergency. Yeah, it depends on the kind of emergency the child has. There are
Mm,
certain things I had already mentioned, and there are certain things that would show up at certain times of the day, that if you notice on time, it would avoid you being in that kind of difficult, precarious situation where maybe it's the dead of night and then suddenly you notice this. So I think what I can advise is that if we are observant enough, okay, if we can try and pay attention, like I mentioned, the vomiting, if it's greenish and it's going on and on. For surgical conditions, it's kind of tricky because you can't say, oh, give something by mouth. I mean, the baby is going to vomit it out anyway. So it's a little bit tricky. But for the trauma I mentioned, you splint the limb. For the child that is not passing urine adequately, it's not the kind of emergency that, oh, you must do something that night. So for the ones that are not passing urine very well, you can just take note of it first thing in the morning. You get to the hospital near you. If it's a health center that is near you, you can get there, and then they would advise appropriately that they may be able to advise you on the next best hospital to be able to attend. Okay. Thinking again, for the hernia, for instance, what I try to say, if a baby has a swelling, okay, if you've noticed that the swelling is there, what you can do, okay, not like treatment, but just to try and control it. If you notice that the child is crying, maybe the child is hungry, hasn't fed, and is crying for any other reason, because some others tend to mistake a hernia coming out because the child is crying and the hernia being out because it's the baby crying because the hernia is not going back. I talked about the swelling in the groin, the swelling around the genitals. Now, when the baby has a hernia, if the mother notices this thing before, and you notice that the baby is ill from any other cause, or the baby is crying excessively for any other reason, you can just gently place the palm of your hand over that area you know the swelling comes out from. If you can place the palm over the hand, over that area where you know the swelling usually comes from, just place your palm over there so that as the child is crying, what's happening is that the intestine is trying to push out of that, out of that opening. Okay. So if you just place a hand over there, you may be able to at least, prevent it from coming out. So obviously, and getting stuck. So for that one, that's the only, measure I can say that one can apply. And it's not as if this is like a standard thing. It's just the basic thing you can do. But the most important thing is early recognition. For most surgical emergencies, there are a few things that you can say or you say, oh, I can do this and I can do that, okay? And it's not, some things are not usually, oh, I can give this medicine and that will solve it. That's just the peculiar thing about surgical emergencies. Except if it's an open wound, you know what to do. Apply pressure so that it can reduce the bleeding and all that, yeah.
All right. Thank you so much, Dr. Oge. And it's been wonderful having you talking to us on Ask the Pediatrician annual conference. As always, we've learned so much. And like Dr. Oge has told us, please, if you notice any of these things, I'm just going to summarize in 2 minutes because we have our next presenter coming out. If you notice any of these things, like a child who is vomiting, blood is stool, don't always assume it's dysentery, and irreducible groin swelling, please make sure you take the children to the hospital immediately. And one other thing Dr. Oge stresses, especially for the newborns, is the fact that they must be checked before they leave the hospital, because some of those surgical emergencies occur in the newborns, and she has clarified to us today that newborns can be operated on if it is necessary to save their lives. So don't think, operation is only for the adult or the bigger children. I mean, that's what Dr. Oge does. I mean, she operates babies, including newborn babies. And even she told us that even babies in the womb now, the world has gone to the stage where they can be operated as well. And it's not because we like to cut babies, but because sometimes those operations, they are very important for them, for them to survive. And for emergencies, it is not something we can do something about. So please, even after this broadcast, I will encourage you to still watch the video again and take notes of all the slides, because the slides will be showing on the video, so that you can take notes of some of these things, and so that when you see them or you see them in your neighbor's children, don't tell them go out to prayer house or church or anything like that. That's the time to go to the hospital. So I want to just thank Dr. Oge for coming. We appreciate you. Thank you so much. You really helped. I mean, we really enjoyed so much. And so we look forward to having you another time talking to us about the pediatric surgical conditions. Thank you so much, Dr. Oge. Thank you for coming.
Thank you so much. Thank you so much for having me, Dr.
All right.
Yes.
Yeah, you're welcome. Okay, so
Thank you
next,
for
all
viewing.
right, Dr. Goodbye.
Bye
So
bye.
next, so we're going to the next program, and that is we're going to have our pediatrician, and that is Dr. Uche Anene-Nzelu. And Dr. Uche Anene-Nzelu is a pediatrician. She's one of the senior registrars at the Lagos University Teaching Hospital, and she's also a Nelson Mandela Fellowship awardee. And so she's a wonderful lady, and she's been on Active Pediatrician. She's very passionate about newborn, and I'm sure she has a lot to share with us today. And so, Dr. Oge is going to be talking to us about emergencies in the newborn period. And so, it's a pleasure for us to have Dr. Oge on the show tonight. Dr. Oge, you're welcome. Sorry, I said Dr. Oge,
Thank
Dr.
you.
Uche. Apologies. Okay, Dr. Uche, you are welcome to Ask the Pediatrician Live. And today, this is the second topic for today, and you're going to be talking to us about emergencies in the newborn. And we're very happy to have you. So, you're welcome. Please go ahead and talk to us. So, just for our viewers that are just joining us, as usual, please take note that for the first 30 minutes or so, we will not feature your question because we want you to just listen to Dr. Uche Anene-Nzelu as she talks about newborn emergencies. And once she finishes, then we will prompt you. But you can drop your question as comments, but we'll only start to answer the questions after the presentation by the speaker. So it's my pleasure to have in the studio with me as the Pediatrician Live Annual Conference 2018, Dr. Uche Anene-Nzelu. Dr. Uche, how are you doing?
I'm very well, thank you.
Yeah,
Thank you for having
you're
me
loud and
today.
you are clear. We are ready to learn. We are ready to hear from you. Thank you so much. So go ahead,
Okay.
please.
Okay, welcome everyone who is viewing. I can see we have about 45 viewers online with
Yeah.
us. You are all welcome. It's a pleasure to be with you all today and to share experiences and to help mothers. It's very disheartening when, and especially for things that could have been prevented or things that could have been handled early. So in line with that, our topic today, emergencies, like Dr. Bemi has said earlier. And so I'd like to start by defining a neonate. A neonate is a child in the first 1 month of life. So from the
Okay.
time a child is born, a neonate is a
Yeah.
child in the first 1 month of life.
Okay.
That is to say, from the time a child is born to the time the child is 1 neonates. And then why are they important? Neonates are important because they cannot tell you what is wrong with them. It's difficult. If you don't pay attention, then you're going to miss a lot of things.
Okay.
They are so tender, they are so young, they are so fragile, they are so vulnerable, and so careful attention to their needs need to be paid.
Mm.
And emergencies, I'm sure we all know, but just to define it again for the purpose of this interaction, are events that need to be attended to urgently and immediately.
I think that is a
If
recurrent theme now in our
that,
presentation. So
and
emergencies
it
are
is
immediate.
exactly
Yeah, go
like
ahead.
life threatening. And if
Yes.
if attention is not paid immediately, it can result in very severe outcomes. Now, for a neonate, a neonate is born, and I'll go on to tell you what is expected normally of a neonate. That means anything that differs from the expected suggests there's a problem. So a neonate is born. At the time of birth, you expect a child to cry. Once a child is born, you expect the child to cry. After the
Mm.
child cries, the child begins to breathe. Those that have attended deliveries, you try to clean up the child and dress the child up, and then you give the child over to the mother. The next saying is for the baby to begin. The baby should mother's breast within the first 30 minutes of life. And after the baby begins to suck, life has begun for that child. Once the baby cries, life has begun for that child. And what are the important things in life? Eat for the baby, sleep, and excrete waste. Eat, sleep, and excrete waste. So they cry, they begin to eat, then they sleep, and then they pass stool, they pass urine, and life goes on. And then you expect them to begin to grow in size, to grow in weight, to grow in height, to grow in development, and so on. So any deviation from this norm becomes a problem. And with neonates particularly, most of the sicknesses they have will present with very similar symptoms. And what are their normal symptoms? Their symptoms can be anything ranging from a fever, that's a body temperature that is high. When we say fever, people would typically in Nigeria think we are talking of malaria and illness. Fever simply means a temperature that is hot, when the
Yes,
body is
it's
hot.
hot.
It can be abnormal cry. It can be difficulty with feeding. So this child, when you put the child to the breast, is unable to suck, and many other things. So I'm going to take them one at a time. So we go back to at birth. A child is supposed to cry at birth.
Okay.
When a child does not cry, it is a problem and requires immediate help.
So failure to
Instant
cry
help.
at birth. Yeah.
Failure to cry at birth, the very first problem that the child can have, and immediate help. We give a window of about 5 minutes, and in the hands of well-trained pediatricians and doctors and other birth attendants, they are able to help a baby to breathe and able to help a baby to cry in the first 5 minutes of life. Then an intervention is required. So this will go out particularly to mothers who patronize unskilled birth attendants, who patronize churches, who patronize homes, or who stay at home to deliver. If you deliver a baby and the baby does not cry, you must seek help. You must seek help. That means there's an emergency and you must seek help immediately. Now, beyond the delivery, we have newborn live with or have done an describing most of the defects, that because the pediatric surgeons usually will be the ones to handle those cases. Once there's a defect in a newborn, you should seek help. Now we go beyond that. The child should begin to suck. In the first 24 hours, you expect a child that is born to urinate. So a child should urinate in the first 24 hours. If a child fails to urinate in the first 24 hours and is going into the second day of life by 48 hours, you should seek help. What does it mean? It means that the production of urine or the excretion of urine may have some problem. You know, when we say most children, there may be outliers. Most children should urinate. So when they fail to urinate, you should seek help. A child should also pass stool in the first 48 hours of life. A neonate. If a child fails to pass for green poo-poo, experienced mothers will know. They would have known that they would have seen their babies pass those poo-poo that eventually clears out and becomes yellow or brown, depending. So a child should pass poo-poo. If by 48 hours a child has not passed poo-poo, sometimes you can stretch it. Like we said, there could also be outliers. You should seek help. Poo-poo, green poo-poo, greenish black poo-poo, you should seek help if the child at that time of life. Now, we had earlier said that in the first 30 minutes of life, a child should be sucking. But it is possible that the child started to suck and at some point stop sucking. Whenever a child begins to stop sucking well on the mother's nipple anymore, that is an emergency. Like we said, most of the problems that a child presents with, the symptoms will be similar. But poor suck, the first thing that will come to our mind, we want to know whether the child has an infection, whether the child has jaundice that has affected the brain, has had meningitis, has had convulsion. It is important that if a mother notices that the child fails to suck or has poor suck, unable to grip he or she would on the nipple in the hands or a trained doctor. Because even though you may just think the child has just refused to suck, it's most likely not the problem. The problem is more severe than you imagine it to be. So once the child is having poor suck, remember, it is an emergency. Like we said in the beginning, most things that affect neonates, children in the first 1 month of life, is an emergency. Almost everything that affects them is an emergency, and you should seek help immediately. So we have dealt with poor suck. The next thing we want to talk about, I know on this same platform we have dealt with jaundice repeatedly, and we know most of you may have heard that some of the jaundice will not be a problem. Most children will have jaundice, and it's not be a problem as long as it's being monitored. But any jaundice that is noticed in the first 24 hours of life is an emergency. So how do you check for jaundice? Once you look in the white part of the eye, like I'm opening my eye right now, the white part of the eye, and there's a tinge of yellow or green. Once there's a change in color on the white part, yellow or sometimes yellowish green, please seek help. And you know, at this point, I want to address the things I had addressed before and link them to what jaundice, for instance, in the first 24 hours of life, or jaundice that seems to be rising rapidly. By rising rapidly, I mean you just notice that the color is rapidly changing. It's getting deeper and deeper and deeper and deeper and deeper. You woke up in the morning, it was a bit yellow, and then by afternoon it's more yellow, by evening it's more yellow. That is an emergency. There is no pawpaw water that will treat it. There is no sunlight that will treat it. There is no abo that will treat it. There is no ampiclox that will treat it. I'm mentioning these things because they are the common things that mothers do. Yes, they are the common things that the mothers do. So once you notice jaundice in the first day of a baby's life, it is an emergency. There are no two ways about it. If you're noticing it from the third day, the fourth day, then even that, like we said, anything that occurs in a neonate should be handled with some form of urgency. Even the third day, fourth day on, it should be measured so that we know if it's a safe level or an unsafe level. But any jaundice at all in the first day of life is an emergency. I will, at this point, note that jaundice in the first day of life and severe jaundice at any time in a neonate's life can cause brain damage. Dr. Gbemi has a lot of them in her clinic. Children that had brain damage at early age. Some of them will go on to have cerebral palsy, have problems with learning, difficulties with movement, difficulties with speaking, things that can be prevented as early as neonatal period, which is the first 1 month of life. So let's not take these things lightly because they are very serious. It is better that you go to the hospital and the doctor examined and does some tests and says, okay, baby is fine, and you go home, rather than stay at home and assume that all is well. And 2 months down the line, 3 months down the line, you're expecting your baby to carry the neck. Baby cannot carry neck. At 2 years, you're still going to church, praying that God will help the baby to walk. Meanwhile, everything can be pointed back to just one simple mistake, one wrong decision for not attending to a child's health. So jaundice is very important, and jaundice particularly because it's something that can be treated easily. Even though in the first day of life it may be a more severe cause, but it also can be treated. Once in a jaundice, we must not play with it. Please note again, jaundice in the first day of life. I'm very particular about my words. In the first day of life, please seek help. It's an emergency. Now, that will bring us to abnormal movement, convulsion. Convulsion in a neonate may not be the typical, the body is stretching and shaking. Pardon my dancing, I'm dancing, but it's just to drive the point home. It will stiffen, it will stretch, this is what you expect in older children. But in neonates, it can come in different ways. It can just come with stiffness of the body, or the body will just get stiff, it may not shake. It can come with abnormal movement of the hand, abnormal movement of the leg. You may see a baby look as though she's trying to smack his or her lips, which may not be normal. So you see baby doing, that is not normal for you. We call it smacking of the lip. It can be a form of convulsion. They can have their neck fall back and stiff, difficult. For those of us that will notice the little space on the head, you can see it will punch up and be tense. If you touch it, it will be hard. Those things call for immediate care. Sometimes they will arch their back and stretch over as if they are bending backwards in a bow. Those things call for immediate help. And once that occurs, you should seek help. Please also note, it is better that you get to the hospital and describe what it is and you are told it is not a problem, rather than stay at home. So you need to seek immediate help in a hospital. Also, maybe something that can help mothers and help doctors, because sometimes we find it difficult to describe these things. In this era of smartphones, everybody has a phone. Once the baby begins to have those things that are abnormal movement, you can take a video as you are getting the child to the hospital. So taking a video does not mean take a video and wait until 3 months, you come and show the doctor. There may be damage at that point. So you take a video as it is happening while you are packing up your bag, dressing your baby to get to the hospital to seek help. Fever is another problem. In older children, we would normally say, especially if they're having runny nose, give paracetamol for 24 hours. If the fever doesn't come down, then you seek help. But for a neonate, once the body is hot, it is an emergency. You must seek help.
Okay.
However, this option, sometimes we mothers wrap our babies with 10
Because
layers of clothes.
because hair must not get to them. Hair is going to cause pneumonia. Is that not so?
No way. No way. Once you wrap them too much, they can have a fever from your overwrapping. That is the only time we can permit you. So if you notice that the body is hot and you notice that you have overwrapped the child, please reduce the layers of the wrapping. You see, the way you feel hot is the way I feel hot, is the way the baby will feel hot. The way you feel cold is the way the baby will feel. We agree that babies are smaller and things may be a bit exaggerated in them, but do not clothe them too much. So if the weather is typically very hot, 1 layer of clothing is okay. Please do not expose the baby at any point, but one layer of clothing in a hot weather without any extra additional clothes is fine. But if the weather is cold, of course, the way you will want to get a cardigan or a wrapper to put over yourself, that is also the way you should increase just a little bit, an extra layer to keep the baby warm. So, in the absence of overwrapping, once a neonate's body, and again, a neonate is a child in the first 1 month, please take the child to the hospital. For those of us that have the benefit to use it appropriately, you can check the temperature. A fever is any temperature above 37.5 degrees Celsius. Like I said, you must know how to use it appropriately, because some mothers will take the armpit up and put it, and the probe will extend all the way to the back and will be measuring the air in the room instead of the temperature of the child. So you must know how to use it appropriately. So once a neonate has a fever, please bring to the hospital. I will keep repeating it. It is better you go to the hospital and you are told your baby is fine than you stay at home and time down the line you would regret this decision of staying back at home. Now, abnormal breathing. What do we mean by abnormal breathing? Any neonate that begins to breathe very fast. Any neonate that begins to have noisy breathing. Any neonate that is having difficulty in breathing. You can see the child struggling to breathe. All the body, all the chest is going up with so much stress and effort when the child is breathing. That is abnormal breathing. So you would have noted the pattern of your child's breathing from birth. So you will know, mothers usually have the eye, they will know when it has changed. So once there's a change in the breathing pattern of the child in the first 1 month of life, please, is an emergency. That child to a hospital immediately. So again, the abnormal breathing can be, it will become very fast, faster than normal. It will become difficult. It will become noisy. If you take off the child's chest, you'll be seeing the ribs go in and out, in and out. You'll be seeing just between the chest and the stomach or the abdomen, you'll be seeing a groove. Once that happens, it's an emergency. You need to seek help. Another problem that you will require immediate attention will be when a child changes color. What do we mean by color? So when a child is born, normally you see the lips will be pink, the hands, the palms will be pink, the soles of the feet will be pink. Some people, their faces will even be pink and even be red at some point, some children. Once that color begins to change to blue, or once it changes to blue, especially the lips or the tongue, the child cries and you see that the tongue and underneath the tongue is blue, please, that is an emergency. In pediatrics, we say it is cyanosis. So for those of you that want to get more information, you can check it up. It's called cyanosis. It is an emergency. It has to do with how oxygen is circulating in the body of the baby. It means oxygen circulation is not sufficient, and a number of things can cause that. So you need to get that child to the hospital immediately. Some children are born with an abnormality that will make them be blue all the time. But the different things, like we said, can cause those things. So you need to get to the hospital so that the child will be assessed and know how to manage that kind of color. Some of them is a heart problem, that surgery will be planned for. And while waiting for surgery, there are some medications that the child will be put on to help the child to live and, to live normally before the surgery is done. In some others, it may not be the heart, it may be other things that require an immediate intervention. So the child, once you see the blue, go to the hospital, let the child be properly assessed. We can plan for, the management and on. Now, another thing is unconsolable crying. We expect a child, like I said while I was introducing the topic, to eat, to sleep, and to excrete waste. And excreting waste is poo-poo, wee-wee, eat, sleep. Then, of course, they may cry in between. But when a child, a neonate, begins to cry unconsolably, meaning you have tried to feed the child, you are sure it is not hunger, you are sure it's not the diaper, you have changed the diaper, you are sure it's not sleep, you are sure something is not in the body irritating the child. Once you are sure of all of these things are away and the child is still crying despite all your normal efforts to console a neonate, then you should see. A neonate should sleep at about 16 hours on the average. So a neonate that rather than sleeping is crying, always crying, you feed, child is still crying, unable to sleep, please seek help. It may be something more sinister than you imagine. Okay? Now for burns, if a child gets any form of injury, what injuries? Mother mistakenly, hot water pours mistakenly, even if it's on a finger, please seek help because it's a neonate. Or something hurts the child has an injury, hot water, iron, fire, any of those burns, any injury whatsoever that a child has, a neonate has, please seek immediate help. Also, you mistakenly give overdose of a medication, for example, or maybe a nanny or an elder, a small child but older, decides to take care of baby brother or baby sister and decides to feed baby brother or baby sister with what baby should not be feeding. So any chemical, anything that is not food for the baby, please seek immediate help. Some children, maybe you left your baby with your 4-year-old or with your 3-year-old, and the person decides to be a nice person and decides to go and give baby a bottle of medicine or a
newborn?
bottle of something else.
Please don't leave newborns with. We don't leave
Please
newborns with
seek
any other person apart from the mom.
exactly us back to. So it should be the mom. I'm saying this because just last week I noticed a 4-year-old whose mother had left the child with a neonate. And the girl, in fact, we will call an emancipated minor because she was carrying the baby so well, but that is very risky. That 4-year-old is still and shouldn't be taking care of an infant. So mothers, please, in the name of God, you should be the one taking care of your baby at every point in time. And I feared for that baby. I had to intervene because she was carrying the baby and she could have dropped the baby. Imagine that the baby just fell off her hands and dropped the baby. That can be disastrous. Please, mothers, take note. Don't leave your newborns, your neonates, your infants with little children. Please endeavor to be the one taking care of them at every point in time. If you cannot, please hand over to a responsible adult. The key word is responsible, a responsible adult. So any form of injury, a neonate falls from a height, has hot water injury, fire injury, burn injury, cut injury, any form of injury, please seek help. Or has any form of poisoning. And when we say poison, we don't mean poison sent from the village. Poisoning means anything that a child, it means anything that a child should not be taking that he takes, or drugs in overdose. They are all poisoning.
Thank you for the
Please seek
clarification.
help immediately.
Yeah.
Yes.
Okay,
Now,
Dr. Uche, we have about 5 more minutes for you to round up so that we can have time to take the question and answers. So for those who are our viewers, kindly send in your questions now as comments so that we can take them immediately. Dr. Uche rounds off our presentation. Please kindly note that you should ask questions related to the topic, because I'm seeing a lot of comments or general questions. General question, please send it to Ask the Pediatrician Facebook group. We're discussing pediatric emergencies. We're discussing newborn emergencies. So if your questions are not related to that, kindly do not send to us here. You can post directly on the Facebook group and our moderators will address them. But please, we plead with you to ask questions related only to the topic, and try and keep it short, simple and short, so that we don't, if it's too long, we may not be able to see everything and we may not be able to address it. Thank you so much. Okay, Dr. Uche, back to you.
okay. So just to round up, we had said, I want to run through again. We had said that a neonate is a child born, a child in the first 1 month of life. And emergencies are events that need to be addressed immediately. Otherwise, they will cause severe outcomes and even lead to death, which nobody wants. And we have listed a number of emergencies. We've named fever, we've named jaundice, especially in the first day of life. We have talked about bluish discoloration of the body, even white, a child just suddenly becomes white. I forgot to mention any trauma at birth, any injury during child delivery. Maybe they were trying to pull out with forceps, or during delivery also requires immediate attention. We talked about poor suck or inability to suck. We talked about inability to pass urine in the first 24, maximum 48 hours of life. We talked about inability to pack that dark green stool also in the first 48 hours of life. We talked about injuries, burns. We talked about poisoning, abnormal cry, excessive cry, unconsolable cry. These are emergencies. Now, final word, treatment.
Okay.
The management treatment is, please go to the hospital. It is a neonate. There is no ampiclox. There is no ampiclox. There is no first aid. Please go to the hospital. There is no pawpaw water. There is no sunlight. There is no ampiclox. There is no ampicillin that will treat it. It is a neonate. Neonatal emergencies will need always to be addressed by a doctor. Please.
Pediatrician.
By a pediatrician. Thank you.
Okay.
Thank you so much.
Thank you so much, Dr. Uche. I mean, that's been a wonderful presentation. And if I can just summarize what Dr. Uche Anene-Nzelu has been telling us, basically is the fathers. Anything in newborns basically can be an emergency. I mean, newborns are so fragile. That's just a summary. Anything you notice in a newborn, don't assume you know what is causing it. It's better you take that newborn to see a pediatrician. And newborns are so fragile. I think I mentioned, maybe I didn't make mention of it during my keynote address yesterday. The fact that the majority of deaths, 40% of deaths under the age of 5, actually occurs in the newborn period. So we lose a lot of newborns. And why are we losing our newborns? Because mothers don't take issues in the newborns as emergencies. And so basically that is why we decided to bring the newborns out as a separate group. You know, we're talking pediatric emergencies, we've talked about emergencies, generally medical. Dr. Oge has talked about the surgical emergencies, but we decided to bring out the newborn group. They have the pediatric emergencies, they have their own surgical emergencies, but they are so fragile. Any symptom, anything that is unusual, as simple as a newborn baby not just looking unwell is enough for you to go to the hospital and it's an emergency. Thank you so much, Dr. Uche. So we begin to take our question. Can I plead with us? Let's keep our questions simple, short. If it's too long, it will have difficulty reading it. And please keep it related to the topic of discussion. This question came in why why Dr. Oge was sick on what could be the cause of a 2-year-old boy suddenly developing K-leg, and used to have K-leg at the first stage of walking and things like that. Okay, so developing K-legs has nothing to do with emergency. It's not an emergency. It's a question you can post directly on the group and we will tell you the answer. Basically, you need to see your pediatrician, but that's not a pediatric emergency. So kindly please send us questions related to pediatric emergency. Okay, so Khadijat is telling you if you want to share the video, click on the share button and you can share on your page, you can share anywhere. Thank you. All right. Okay. Oyekon is saying thank you. I think she asked question previously. We answer. Okay. This is a question from the watch party. Okay, because like I said, those of you watching from the Ask the Pediatrician Facebook group on our watch party, we need to bring your questions to the page so that we can feature it on the on live so that we can see the question live. So Dr. Okay, so Vera is asking a question about hypospadia. So unfortunately, Dr. Oge is out of the studio now, but I think Dr. Oge did mention that if you notice anything like that, then you really need to take the child to the hospital. If a child the kid's penis is deformed after repair. Oh, okay. So this child has been operated before and it's now deformed again. Then you need to go back and see the pediatric surgeon, and I'm sure they will address that as well. Okay, let's see the next question. Oluseyi Oyedotan is asking, thank you for a good job, well done. What could possibly cause a baby of 1 year plus to constantly have runny nose? Okay, so Oluseyi, that is allergic rhinitis again. This is not a pediatric emergency. You can see your doctor, even your general doctor will take care of that. Okay, Dr. Kingsley Uzebiro is also giving us a comment and saying thank you. Thank you, Dr. Kingsley. We appreciate your comment. All right. Another person is saying here, okay. The network is really bad. It's not audible, but please, I'd like to ask what can cause teeth that have been removed for over 9 months not to come up again? This is a dental question. Maybe tomorrow we're going to have Dr. Buki with us, and Dr. Buki will be talking about pediatric dental emergencies, but you can ask her your question. But I think you should go back and see the dentist, but that is not really an emergency as well. Please send us questions about newborn emergencies. That's what Dr. Uche just talked about, and that's what she really wants us to we will be able to answer question on. Yeah, Oluchi Bubeto is saying, Dr. Nzelu, great job. Well done. Okay, thank you for the feedback. Inkiru saying, thank you, doctor. Thank you. Okay, so finally we have a question. From Oyekon, what do you have to say about doctors giving ampiclox to newborns after delivery? They say in case the baby might have traces of jaundice. Dr. Uche, what do you say to that? Dr. Uche, are you still with us? Dr. Uche? It seems like we're having a break in transmission there. Dr. Uche? Okay, just give us a few minutes. Let me see what's going on. So Oyekon is asking. Okay, yeah. Dr. Uche, can you hear me? Dr. Uche, can you hear me? Yeah, we have a question for you about Oyekon is asking, what do you have to say about doctors giving ampiclox to newborns after delivery? They say in case the baby may have traces of jaundice. What do you have to say to that? Okay, okay, I think Uche seems to be having connection problem. Basically, we don't recommend ampiclox to be given to newborn babies during delivery. We newborn babies don't need ampiclox at all. So, Yekon, that's the wrong practice, and it is wrong to give antibiotics to newborn. Uche, are you back? Okay, so it is a wrong practice to give ampiclox to newborn babies. What I'll recommend, if the baby has jaundice, ampiclox is not the treatment for jaundice. And if you have followed us on our Ask the Pediatrician Facebook group, there are many causes of jaundice, and 60% of jaundice are actually due to um, what we call physiological jaundice. Most of them don't require treatment, but a few jaundice sometimes it depends. So jaundice could be caused by uh, infection. In that case, they require antibiotics. But most jaundice are not due to infection, and if they are not due to infection, they may not necessarily require any form of antibiotics. So it is wrong practice to give ampiclox routinely to newborns just because you are suspecting or you think they may have jaundice. No, the ampiclox should only be used only when there is sign that those children have infection. Okay. All right. Gloria is saying thanks, Dr. Nzelu. Uche, are you with me? Okay. All right. Let's move on. Um. Dr. Victoria is saying great job, well done, pediatrician. So, uh, thank you, Dr. Victoria, for the feedback. Okay. Dr. Uche, are you with us now? Okay. Another question from Ibukun here is saying that I noticed discoloration on baby's eye on the fourth day. I went to the hospital. The doctor checked him and prescribed antibiotics and suggests that I put him on daily morning sun. The discoloration eventually cleared, and my fear is that no test was carried out on him to know the level. I hope he's fine. No, that is actually wrong practice, Ibukun Araromi. It is wrong practice for any doctor to treat jaundice without checking the level of jaundice, because the level of jaundice is what will determine the appropriate treatment. Like I said, some jaundice may be physiological and may not require any form of treatment. Uche, are you back? Okay, so they may not require any form of treatment, whereas uh, some jaundice require that even the baby's blood be changed immediately. So if you are not if a doctor sees your child and the doctor thinks the child has jaundice and the doctor is just saying put on the early morning sun and give antibiotics, that is very wrong practice, and that's a very dangerous practice. And that is why one of the things we were emphasizing, and I when Dr. Uche was talking, I did mention in the father, kindly take newborns to see pediatricians. I always emphasize that not every doctor can treat newborn babies. Most times they don't just know what to do. So it is better you take your newborn to see the pediatricians, because the pediatricians are the ones that are really trained in handling newborns. So I hope your baby is fine, but I cannot give you any guarantee because nobody did a test and nobody knows how severe the jaundice was. So it is difficult for us to say your baby was fine or not. But I would say encourage you to take that baby to see a pediatrician. Maybe when you see a pediatrician, then they will be able to give you examine your baby and hopefully be able to advise you further. Okay. All right. Tara is asking, is it advisable to wash a newborn baby's mouth with dry gin or gogoro? Ha. Because my mother-in-law used it and my 4-day baby sleep over 12 hours without waking up. Uche, can you answer that question?
Tara, thank you for bringing this and for being bold to say this on the media. It's baby's mouth with. In fact, this is what I can even say this is a form of poisoning, like I had earlier mentioned.
Yes.
Things that a child should not take. You can't be giving a child dry gin or ogogoro. It's alcohol essentially that you're giving to the child, and it's poisoning for that child. Please do not do it again. It's good you have thank God for the one that survived, but please do not do it again. Please, it's not advisable. It's a no. You can clean your baby. I'm sure Dr. Buki Olatosi is going to talk more about, dental care, but you can just use, a piece of towel and water and clean the mouth of your baby, maybe with a little pinch of salt in the water. But please, it's a no to use ogogoro or any other substance to clean your baby's mouth, or 4 days, please.
Me, and I'm like, Tara, you were sitting there and you're watching somebody using dry gin or gogoro on your baby. I mean, I don't know whether you listened to me yesterday. This is one of the things I emphasize about it. It is your baby. Even though it's your mother-in-law, you got to take your stand. In other places, that kind of thing will be termed child neglect or child abuse. For you to use alcohol, as an adult, I can't even use alcohol to wash my mouth, and I'm an adult. So how can you now use it on a newborn baby? And then no one, I mean, the baby will be intoxicated. That's why your baby was sleeping. I'm happy the baby survived, but please tell mama and tell everybody that is very dangerous practice. And that's one of the reasons why we have asked the pediatrician, please don't do such thing again. Thank you so much for asking. Okay, Ibukun is asking, Olufumilola is asking, is it normal for neonates? Yeah, so for those of you on our group, our moderators are helping us to pull your questions so that we can show it and ask. Is it normal for neonates triplets of 2.1, 1.7, and 1.8 not to be placed in the ICU? Dr. Uche.
Okay, good. You asked the question. So, different protocols for different ICU, but like Dr. Boyede had earlier mentioned, depends on the age, gestational age, that's the age of the pregnancy, and the weight of the child.
Yeah.
And again, depending on the protocol. So most people will be comfortable to send a 1.5 kilogram child home.
Yeah.
But this is after they have taught the mother what to do, what not to do, how to care for the baby.
Yes.
So a 2.1, 1.7,
That's
1.8,
good.
I
Yeah.
think they are fine.
They're
So
fine,
they will
yeah.
not need an intensive care. They may have been monitored for a day or two
Yeah.
before sending home. They would not have needed an intensive care.
Yeah.
Like you're asking.
Yeah.
So it's normal.
Yeah, thank you, Dr. Uche. So just to add that the fact that babies are born preterm or born premature does not mean they have to go into intensive care units. If they have good weights and they don't have any of those emergencies that Dr. Uche has talked about, then they will be fine. I will not put a 2.1 or 1.7, 1.8. I will not put them in the incubator either. If they don't have any other medical emergencies, they are going home, and all they need is breast milk and keep them warm. So basically that's what they need. Okay, thank you, Gloria, for the thumbs up. Thank you, Abdurasak, for the thumbs up. Thank you. Oyeko Molara is still asking, please, can you shed more light on circulation of oxygen as connected to crying in babies and lung exercise? Well, that's a big one. So tell us.
I'm not sure what you mean by lung exercise.
I think she's trying to talk about asphyxia, possibly, and the fact that sometimes some people believe that crying in babies is an exercise and they have to exercise, and so that is why you have to beat babies so that they can. I hope I'm saying what you are having in mind, Oyeko Molara. If I'm not, kindly update your comments and let us know what you really have in mind. So, but I'm going to look at it from that perspective. Dr. Uche, what do you say to that?
Okay, so I'm going to run a quick one in 30 seconds. When a child is in the womb, the child is inside water. So even the lungs are filled with water. When a child comes out, the child needs to breathe. And most times, the first breath of the child is a cry. When the child cries, the lungs open up And once the lungs open up, air goes in, and then oxygen begins to go into the system through the lungs. Inside the womb, oxygen used to go to the child through the blood vessel, the umbilical cord connecting the mother and the baby. But once the child is born, the child needs to now sustain his or her own oxygen, and that can only come from the lungs. So that first cry is like the first breath a child takes. Once the child takes that breath, the water in the lungs reduces and eventually completely is cleared out, and oxygen begins to enter the system of the child. But that does not mean that a child that does not cry requires beating. Please do not beat. I'm following up on how Dr. Gbemi explained the question. Please do not beat. You will cause more harm from beating a child. What the child requires is
Oh, sorry, we're having bad network.
help the baby come to hospital with pediatricians, most especially, so that they can help that baby breathe in the first 5 minutes of life without causing a scar. You don't even need to beat the baby. You don't even need to the baby used to give the baby air, and the baby will be fine. So please, no beating. Thank you.
All right. So, Oyeko, I hope that's what you are asking. But if that's not what you're asking, please update your comments and then Dr. Uche will answer it. So Mobolaji is asking, Suzanne Ajibua, is it possible to exclusively breastfeed twins, Dr. Uche?
Mobology, yes, I think it's possible to exclusively breastfeed twins, but it depends on the mother's commitment to. It depends on the
Well,
commitment.
Uche, we've had twins that have been exclusive breastfed on Ask Pediatricians, and I have the video, I have the photos. So just go to the group. Mothers have exclusive breastfed twins on ATP, and their pictures are there, and the babies are fine. So you can. So but like Dr. Uche is saying, you girls got to be very committed. You got to, and that's what that mom said. Initially, people were telling her that she can't do it, she can't do it. But when she came to ask us on ACP, of course, we are going to tell you you can do it. And she was encouraged. And I mean, that's all she needed, just that encouragement and motivation. And she did it. And we saw the twins picture at 6 months. They were looking so lovely. And like I keep emphasizing, I know I talk a lot about breastfeeding. It is about the protection. It's not just about the food. Okay, so you can do it, Mobalaji.
And for daddies that are listening, your support is also required so that mommies
Yes,
can
yes, please, Daddy, don't struggle the breast with our babies. So at that 6 months, let the babies enjoy breastfeed so that they can live and enjoy and be what they want to be. Okay, so Kafila from our watch group party is asking, is it good for a month-old baby to be turning her neck around? I don't know what she means
Well,
by
I
turning
don't
her neck
understand what you
around.
mean by that.
There's
Yes,
nothing
the
wrong with the
baby
baby
should be
turning
able
their
to
neck.
move
If you turn
around.
them, okay, all right. Yeah. So there's nothing wrong with them turning their neck. Oyekon is confirming that what I said about what I said
Yes,
is right.
that's
So you
okay.
answered that question correctly. And Ebere is asking, is it normal for a baby of some months mouth to smell, and how can it be prevented? Okay, Ebere, why don't you join us tomorrow when Dr. Buki Olatosi, the dentist, will be here, and she will talk about how to clean the mouth and all the dental emergencies. So let's just leave Dr. Uche to undo the newborn. I'm rushing now because we have our last speaker is already in the lobby waiting, and we still have quite a lot of questions for Dr. Uche. And Abosede is asking, what makes a baby grunts a lot in sleep and doesn't pull as often since about 4 weeks? It pulls about 5 days and 6 days. So let me just say, if you're asking the pediatrician questions, you should always tell them how old your baby is. Because we pediatricians, we take care of babies from 0. In fact, we take care of babies from the womb to 18 years. So baby and I found mothers who call their 18-year-old babies. So saying baby does not make any sense to a pediatrician. So you've got to tell us how old the baby is. So if Abosede is listening to me, can you update your question? Because I won't want us to answer the questions the wrong way. Because, for example, in a newborn baby, there's nothing absolutely wrong with a newborn baby passing stool every 5 days or every 6 days. In fact, they may not pass stool for 2 weeks. As long as their tummy is not distended, like Dr. Oge said in her presentation, they were not vomiting or they are not having swollen tummy and all that. That is perfectly normal. So can you be specific with what baby we're talking about here so that we can ask Dr. Uche? Okay, Sha. So Yoko is thanking us. Thank you so much. Thank you for joining us and thank you for asking your question. Okay, Abosede is asking, oh, so many questions about how to clean baby's mouth. Please come tomorrow. Dr. Buki will be here and she will answer you. All of you asking about mouth. Okay, it is not a newborn emergency about how you clean your baby's mouth. It's not an emergency. I can assure you about that. And um, Dr. Buki, who is our pediatric dentist expert, will be here tomorrow. And okay, so another question about how to clean the mouth again. So let's move on. Okay, Mobalaji is asking, my 5-month-old baby snores while sleeping. Is this something to worry about? Uche, do you want to answer that? Oh, I've lost Dr. Uche. Okay, it's not a newborn emergency anyway, but can you please post that question on our group? When you post on the group, we will have we will answer it for you. So there are conditions that will make a baby to snore, and so that baby need to be seen by a doctor, preferably a pediatrician or a ENT doctor, who will now be able to tell you. Yeah. Okay. So yes, Abasade is updating our question. So Abasade question on Ania. Did she ask a question on Ania? I'm not sure I saw any question on Ania. The question
this
is
a different person.
I think it's a different person. The person who asked a question about baby, I don't think is Abosade asking about Ania. And she was asking about baby not passing through.
Poo-pooing.
Yeah, but said this question is about a baby who grunts a lot in the sleep and doesn't poo. That is not hernia, so I'm not sure whether they are related. So, if that baby is 6 weeks old, Dr. Uche, how will you answer? Let's assume it's that same baby and baby is 6 weeks old. The baby is grunts a lot and it doesn't poo it poos only every 5 days and for the past 2 weeks. What will you say about that?
Okay, so for the baby grunting a lot, like we had earlier said, once there's a problem with respiration, you need to seek help.
Yeah.
So a number of things can cause it. So the person should go and see a pediatrician. That's for the grunting or having problems with breathing while sleeping. But for the baby, not pooing once, if it's a hard bean, if a child used to pass through once a day, twice a day, 3 times, and suddenly begins to pass, it just in one night decides that it's not good, then maybe we also need to assess the child. But like Dr. Boyede earlier mentioned, some children would have by this time developed a pattern of defecating. So if it's a change in pattern, then we may need to assess it. But if it's not a change in pattern, then I
Yeah. Okay. So
the child is fine.
okay, so thank you so much, Dr. Uche. It's been wonderful having you on the show. Well, thank you. I know that we struggle a lot with some of your network connection, but eventually we're able to get you. And so, just to say that even if you still have questions, because we're going to go to the next person now, and if you still have question, you can. Oh, sorry. I think we have a last question from Abosede. He's asking, how can I get rid of umbilical hernia? I really do not like it. Any remedy apart from surgery? Dr. Uche, do you want to answer that?
Okay, so again, age and hernias, umbilical
I think
hernias,
our baby is 6 weeks. I think our baby is 6 weeks.
Okay. So a certain size will close eventually, depending on the size. So if it's a certain size, it will close eventually. If latest by 2 years, it should close. But if it doesn't close, then we may need to seek help, and it's certainly only surgery. At least as at for now, it's only surgery that will help you to close it. But if it's a certain size, you give it some time to close.
Yeah. Okay. So basically, Abosede, it's not about whether you like it or not. It's a matter. So when it comes to newborn health, we don't worry about cosmetics. I know mothers worry a lot about cosmetics. So please don't subject babies to things because you just don't like the way it looks. Most pediatric surgeons will not operate hernia. And Dr. Oge of Slides, but I'm sure that's what she would tell you. They don't operate it until like sometimes 5 years, if it is, if it's really big, because sometimes it will close on his own, like Dr. Uche just said. So there's really no need to subject a baby to risks of anesthesia, risks of surgery, just because you don't like it. So just leave the baby alone. If the baby has symptoms suggesting of obstruction of the hernia and all that, yes, then you can go and see the pediatric surgeon, then they will do something about it. But just because you don't like the fact that your baby has idodo or tummy, it's not enough for you to go and worry. So it's not something to worry about. Just relax, okay? All right. So finally, I just want to say thank you to Dr. Uche for being we still have last question. Okay, let's just take this last one, and then we'll go because Dr. Our next speaker is around. Yeah. I'm not sure I understand your question, Dukwe. My baby is 4 months and 3 weeks and doesn't sleep for strength. Or do you mean for stretch? Okay, maybe a stretch of 30 minutes
Right.
without stretching himself. I don't understand. But if you're worried about okay, Uche, do you want to address that? Our baby is not sleeping for too
Okay.
long. I think that's basically what she's saying.
Well, I'm thinking she's saying baby turn around when they
That
sleep.
maybe the
But
baby
if you're
stretch or something.
But if you're worried there's an abnormal movement, like we said, maybe take a video of it and
Yeah.
see a pediatrician. Let the
Yeah.
person see and help you assess.
Yeah. Okay, so basically, that's how much we'll be able to take with Dr. Uche. Thank you so much, Dr.
Thank you so
Uche.
much.
You've been
Thank you
so
so
much
much.
a blessing to us today. And if you still have questions,
Thank you
please
very
drop
much.
it on our group and we'll be able to answer it. So we're going to have our next speaker on now. Uh, our next speaker is Dr. Renner, and Dr. Renner is a pediatrician at Avon Medical Center. And Dr. Renner is going to be speaking to us tonight about um, aspirations when things go the wrong way. So as usual, again, we're going to allow Dr. Renner to talk for like 30 minutes or thereabouts. And after that, you can drop your questions in the comments on the group, on our page, and then we'll be able to take your comments. So while Dr. Ayo is speaking, I want you to listen, and after that, you can now drop your comments. Dr. Renner, you're welcome to Ask the Pediatricians Live. We are very happy
Thank,
to have you here.
thank you very much, Dr. Gbemi. It's really good to see you.
Yeah, it's good to see you too.
So this is the first time I'm doing this. So fantastic job to everyone. I think the comments say it all. The mothers, I think, have been extremely enlightened by these sessions, and I'm really happy to be a part of it.
Yeah, thank you so much, Dr. Renner. So you can go ahead with your presentation, and after that, we will take the question and answer. Thank you.
Excellent. Thank you very much. Okay, so good evening, everyone. Good evening, everyone watching us from, well, I guess all over the world. I'm extremely excited to be here this evening, and I'm going to be talking about something that is extremely important. Now, we're going to be discussing what we call aspiration. Now, aspiration, when things go down the wrong pipe, essentially. So let me give you a sort of background on what we mean by pipes. What pipes are we talking about? We're not talking about a hot water pipe. We're not talking about oil pipeline. We're not talking about those kind of pipes. We're talking about pipes that lead from the outside environment into a human being. Now, you know that on your face, you have two entrances. There's the nose and the mouth. Now, the nose leads into the lungs because the nose is what we use to take in air, and the nose gets oxygen into our lungs, and then the lungs does all the work of helping us to breathe, while the mouth takes food in through the esophagus, or what some people call gullets, and gets into the stomach. But sometimes, for some reason, you find out that when a child is eating or taking something into the mouth, for one reason or the other, either talking, bouncing, playing, jumping, the things that children normally do, the food will enter into the place where air is supposed to be going through, which is called the trachea. And the trachea leads into the lungs. And sometimes that trachea is like a pipe. It's essentially a pipe. It's like a tube that leads from the nose straight down into the lungs. And sometimes it can be blocked. It can be blocked by that piece of food or that toy, and that can have devastating consequences, because that's the only way by which air can actually get into our body or into our lungs. And once that is blocked, there is no way for air to get into our bodies anymore. And so oxygen does not get into the child's system, and that can rapidly lead to very horrible consequences. I'm going to have to start this presentation with a very sad story. I mean, sometimes it's good for us as physicians to share our experiences of the things that we've heard and things that we've seen, just so that you have an idea of what we sometimes, when we interact with parents and patients, what we have to deal with sometimes. So there was this lady, she had an older child and she had a younger child. So the younger child was about maybe 6 months thereabouts, and the older child was about 3 years. Now she had prepared yam for the older child, so the 3-year-old, and the 3-year-old, she had cut the yam into pieces for the 3-year-old, and the child was eating the yam. And she went into the other room to go and get something for maybe the 6-month-old, or she went to the kitchen to go and do something else. And before she came, the 3-year-old had offered the 6-month-old a piece of that yam.
Wow.
And Yes, she had offered the 3-year-old had offered the 6-month-old a piece of the yam, and the 6-month-old, collected it from the child. And before the mother came back, the 6-month-old had aspirated or had taken the yam into the wrong place, into the wrong pipe, and it had completely blocked the airway. And try as she may, she was unable to remove it. She rushed the child to the hospital. By the time she got to the hospital, unfortunately, the child had died.
Oh my God.
Yes, really, really, really sad. Yes, extremely sad. It was extremely devastating, for the mother, for the entire family, So, I mean, this was something that, made me realize that, this foreign body aspiration issue is something that is extremely important for us to talk about. Okay. So, as I said, I'm talking about when things go down the wrong pipe. Now, which children are particularly at risk for developing this wrong pipe going down events? Children that are less than 1 year. As a matter of fact, children who are less than 5 years are at more risk of getting things go down their airway or going. So for purposes of being more specific, I would refer to the pipe as airway, because that is the passage through which the air goes through. Yeah. So children that are more at risk of developing aspiration or passage of foreign bodies through the airway include children less than 5 years, infants especially. And then boys, of course, are more prone to developing aspiration or things going down their lungs or going down their pipes, going down the airway, than girls. And of course, this is because children less than 1 year, or children less than 1 year, or children less than 5 years, both the same. They are less likely to be able to control their swallowing as easily as children older than 5 years. And when they come in contact with small pieces of food, if they are playing or talking or bouncing or jumping while they are eating, if something is going to go the wrong way, they are less likely to be able to have the ability to cough hard enough, because what protects us from things going down the wrong way? If you think about times when you yourself as an adult, you are eating and then you are talking at the same time, which you really should not be doing, you find out that when you have things going down the wrong way, what protects you from getting that thing into the wrong pipe is coughing. Especially if you cough with enough force, the thing will come out, out of your mouth. But children, especially young children, don't have that power in their cough to make that foreign body come back out. And so that can be a very dangerous situation. So the other thing is that boys are more rambunctious. So boys are more likely to be eating and talking, or eating and playing, and so they are more likely to have them aspirate things.
Just like any other thing else. They are the risky gender.
They are the risky gender with everything else. They are the risky gender. So it also turns out that, so what are the objects now that children are most likely to aspirate? Now, food being by far the most common thing that children will aspirate. And these foods include small pieces of things like groundnuts. Now, groundnuts, there is no reason why, I might be wrong, but in my personal opinion, I see no reason why children less than 3 years old should be eating one groundnuts. They should not. As a
You
matter
can
of fact,
blend it.
yes, you can blend it. As a matter of fact, even all these sweets that are, that come in wrappers that are one that like Vicks Lemon Plus, they should be given to older children, not younger children who can
Below
actually,
3.
put it in their mouth. Yeah, below 3 years old. They shouldn't come in contact with those things, because the problem with things, organic material, because we call natural materials like granite organic materials. The problem with organic materials is that when children aspirate them, the kind of effect that they have in the lungs can be extremely devastating, because the lung sees them as very bad foreign bodies. Of course, a lot of these things contain protein, meaning that the body is going to see them as extremely terrible foreign bodies and is going to mount a response that will be extremely dangerous. It will cause the lungs to have an infection. So food being very common. So things like groundnuts, things like popcorn, seeds, food that has been cut into little pieces. So as much as possible, let us avoid giving children less than 3 years extremely small pieces of food. I know at some point, there is finger food that babies can play with, but usually this finger food should be mashed food that they can pick up, and then they can, it's soft food, so that if you go the wrong way by any reason, it will just more or less dissolve, so to say, rather than go and obstruct the airway. Now, for other things that children can aspirate, they can aspirate small pieces of toys. So if you look at the labels of toys, certain toys,
Yes.
you actually see that they stated that not suitable for children below 3 years, because these toys contain small parts.
You're right.
So it's extremely important, that, and this is where legislation comes in, because a lot of countries in where these toys are manufactured, the societies and the legislators there mandate that these toys come with those warnings, so that parents are aware that such toys are not suitable for children below certain ages. Now, a child who has had something go down the wrong pipe, how exactly will the child present? What exactly are the signs? What exactly are the symptoms that the child would have? Very common is coughing. If a child was well 2 hours ago and suddenly the child starts to choke violently and cough and have red eyes because of the coughing to an extent that, this is, if a child is coughing because a child has a viral respiratory tract infection or cough and catarrh, the cough would have started a few days, will gradually build up, there will be catarrh. But the child who was apparently well before, maybe was playing or eating or was around, a toy or, around a remote control, and suddenly starts coughing violently, then please note that the child must have aspirated something. The truth of the matter is that even though an eyewitness account is probably extremely important, for a lot of children, you won't get any history of an eyewitness account, because sometimes they'll be playing by themselves. No adult would have been around to supervise them or supervise the play directly, and then suddenly the child just starts coughing. So please, if you notice any sudden onset of violent coughing in any child or choking, then please consider that the child might have had food or toy go down the wrong pipe. The other thing is that sometimes, because in some cases that I've seen, the child was obviously, eating. It was while the child was eating that the choking took place, and so the food went down the wrong pipe, and then and in such a situation, it's quite obvious that it was food going down the wrong pipe or aspiration that occurred. If a child is eating, suddenly the child starts choking. There's sometimes, and I must state it here, that in some situations, I've come across situations where the parent is the one that actually makes the child to aspirate. And this is as a result of what we call force feeding. Now, force feeding must be mentioned at this point, because a lot of parents will say, my child is not eating very well, he's not gaining weight, he's not getting fatter, and then they will turn the child's head upside down and hold the nose of the child like this, make sure that the child knows his head very well, and then they will
have a picture like that on our group.
extremely horrible. And then they will force the pap or the Cerelac or whatever it is down the throat of the child, because they say, this child, if you leave the child, he'll be playing all day, he'll eat only once, he won't let the child play. Just offer small meals more frequently, rather than make sure that the child aspirates, because sometimes when the children aspirate these things, they have prolonged admission, they will have to stay in the hospital for a long time. So still on the symptoms, sometimes they can develop high fever. Sometimes the problem is that a child can aspirate something very small, a very small object, and the child might not present with the violent coughing that I've just referred to. But you find out that the child will keep on having difficulty with breathing, fast breathing. They will keep on treating the child for pneumonia. Child is in and out of the hospital. They keep on treating the child for fast breathing pneumonia. And you are wondering, won't this pneumonia ever go? In such situations, it is important for us to consider that the child might have aspirated something very small and it might have been missed because it's possible that the thing went further down and blocked somewhere further down. It is all these objects that block higher up, the airway higher up, that will present with violent coughing, and you hear what we call a wheeze or a stridor. That stridor sounds like
Dr. Renner, I will recommend you for Lollywood as additional source of income.
we must demonstrate the sounds for them so that they have an idea of what it will sound like.
Absolutely. Very nice. Thank you.
So that's what a stridor sounds like, okay? So if it's a very big airway that has been blocked, that's the child might have that stridor, that noise that we call stridor. But if the object that the child has aspirated is very small and it goes all the way down, the child might not have any stridor. You'll just be having difficulty with breathing, chronic cough. So consider that in a child who has been otherwise well and then suddenly starts to have prolonged cough and then is always being treated for pneumonia in and out. I'm not saying that that's the only thing that can cause a child to have repeated pneumonia, but it is something to consider in a child who is otherwise well. Okay, so when a child has aspirated, what do you do? Now, it's important that you administer some sort of first aid. There are certain videos that are available. And Dr. Boyede, is it possible for you to show us that?
Unfortunately, we will not be able to play the video because they won't be able to see it. But the video is available on the group as well.
Excellent.
We will post it on the group and then you can watch it on the group after the presentation.
Okay,
so we'll pin it up so that people can quickly identify the video about shocking. But I think we have it already, but we can also still put it up again. Yes. So, but if if you play video now, it will be difficult for people to say it. Yeah.
No problem at all. No problem at all. So this so when a child has aspirated in the home environment, it can be very alarming. So the first thing I would say is, please don't panic. Please don't take banyo.
That is like a recurrence decimal now. Don't panic. If you don't take anything away, just take away in pediatric emergencies, don't panic.
Don't panic, because that is key. Because once you panic, you get confused. And once you are confused, you, especially the mother, I mean the fathers, I can't rely on the fathers. I can't rely on the fathers. So let me just face the mother. I know Dr. Uche has mentioned fathers, but let's just face the mothers squarely. Because the mothers are the ones who have a calm head in all of this. So please, mothers, try not to panic. Make sure that for a child who is less than 1 year old, what you want to do is that you want to turn the baby. I don't want to say upside down. They'll put up the pictures, but you position the baby such that the baby's head is a little bit down and the baby is lying on your hand, such that the baby's chest is against your hand, and so your baby is somehow down like that. Let me see if I can use this canister of fleet. So the baby is down like that, the head is down. So this red thing here, that's the head of the baby, and this is the back of the baby. So you want to give the baby in between the back, upper back. You want to use the heel of your hand to hit the back of the baby, because by doing that, you are trying to make the object that the baby has aspirated to come down and out. If that doesn't work, you turn the baby over such that the baby's chest is facing you, and then you press the abdomen. Okay, you press the abdomen, press the chest, so that you can create some sort of air pressure that will make the foreign body to come out. They call it chest thrust. They call it back blows, that one, because they call it back blows because they are blowing the back blows or chest thrust. Those chest thrusts are supposed to create some sort of air pressure to make the foreign body come out. If you have done 5 back blows and the object does not come out, try the 5 chest thrusts. If you've done the 5 chest thrusts and the airway doesn't come out, and the object doesn't come out, then please take the child to the nearest hospital. Please, I repeat, nearest hospital. I find out that a lot of mothers, what they want to do is that, doctor, I wanted to take the child to the hospital where I gave birth to the child. And I'm like, but maybe you had a hospital that was 10 minutes away from your house, but you went from Festac to Ajah because you wanted to take the child to the hospital where they gave birth to the child. Please, emergencies are for emergency. Make sure you take the child to the nearest hospital, not the hospital where they gave birth to the child. Okay?
Yes,
so
not your family doctor.
Not your family doctor. The nearest hospital. Nigerian doctors are well trained. Thank you very much. So any doctor that you've come across should be able to handle those things. Now, what I would say is that not everybody has the presence of mind to do this. And this also requires that you have done some sort of training, you've watched some sort of videos, which is why this kind of forum is important. So when the videos are up, I would like everyone to please go and have a look at the videos. They are demonstrated in those videos. However, if you find out that you have done the back blows 5 times and the chest thrust 5 times and the object has not come out and the child is still having significant difficulty with breathing, please take the child to the nearest hospital for them to do what they need to do. Dip your finger into the mouth, or you dip any object or a spoon or a long thing into the mouth to try to remove that foreign body. What that can do is that it can push that foreign body further down into the child's airway and block it even further. So what was what we call a partial obstruction can now become a complete obstruction because you have pushed that foreign body further down and completely blocked off the airway, meaning that you have not really helped the situation. So please never do what we call a blind sweep. Never dip your finger into the mouth to try to get rid of the foreign body. Now, for a child who is older than 1 year, what you want to do is what we call abdominal thrust. So you will go behind the child. We also call that a Heimlich maneuver. You go behind the child and then you will place your hands like that, your hands in a fist like that over the abdomen of the child from behind, and then you bring the child closer to yourself in a forceful manner, but as much as possible, try not to damage anything. And then what that does is that it creates some pressure that allows the airway to be free. It creates some air pressure that makes the foreign body to be brought up, by the child. And so that is another important first aid maneuver that you can do. However, once again, if you don't have the presence of mind, or if you're not confident enough to do that, please make sure that you take the child to the nearest hospital. Now, what to expect at the hospital? Because I think I should need to give you some indication of what you expect the doctor to do. The doctors, depending on how ill your child is, because sometimes this obstruction can be so bad that the children might actually lose consciousness. They might have convulsions because not enough oxygen is getting into the child because that airway has been obstructed. Some children will just have mild difficulty with breathing. So depending on how ill your child is, the doctor will do different things. But I think at the end of the day, most doctors, if it's very severe, will try to see if they can see the object and try to extract it with certain specialized instruments. Or if your child is not so ill, then they will try and request for a chest X-ray. I had sent a picture of a chest X-ray, which Dr. Boyede is going to put up. A child actually swallowed a nail. So you can imagine children can swallow anything. A nail was actually in this child's trachea. So that picture, so if a child is having that sort of presentation where the child is not so ill, they might do a chest X-ray, which might actually show us where exactly that foreign body is. Now, depending on how far down the foreign body is, because the chest X-ray might actually help us.
X-ray is on now.
Oh, okay, excellent.
Yeah.
Okay.
Yeah.
So once they've localized where the foreign body might be, then what they will do is that they might actually, there's what we call rigid, these are all big terms, rigid bronchoscopy. What that means is just that they will just pass a sort of device that has a camera at the end that might be able to pick up the foreign body and then get it out. If they cannot do that, sometimes they will have to do what we call an open chest surgery, in which they will need to open up the chest, open up the lungs, and bring out the foreign body. Because if a foreign body remains in the lungs, then that is not a good situation, because it can cause infections, it can cause the lungs to collapse, it can lead to ICU admission, so many complications that can arise from this foreign body aspiration. And so it's important that prevention in this situation is far, 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 far better than cure. So let's talk about prevention. Let's see. So I mean, just in addition, they might also give you, most likely to give your child things like antibiotics, especially if it's a solid material. If your child aspirates liquid, because I want to talk about things like, speaking of liquid, a lot of times, a lot of parents would have stored things like kerosene inside Coca-Cola bottle. would have stored kerosene inside
Eva
water bottle, inside Fanta bottle, and then the children, they'll come around, hey, daddy, mommy, yeah, and then the parents go into the bedroom and then they share the kerosene amongst themselves because they think it's inside the Fanta bottle, inside Eva bottle, and so it looks like water. Fortunately, kerosene doesn't taste very nice. I haven't tasted it, but that's what I hear. Kerosene doesn't taste and so once they get a taste of it, they immediately spit it out. But the problem is that sometimes some of it would have gone into their lungs. Okay, so it's important for you not to store any liquids that are not drinkable inside containers that appear to be things that are drinkable. So for instance, don't store kerosene inside Eva water bottles because your children are going to think that it is water because kerosene is clear. Unless you smell it, you might not know that it is actually kerosene. So children aspirate liquids. That's important, including food, including whatever. And those things can cause a bad lung infection that will require the child to get antibiotics. So prevention is key. So as long as children, I read one article that said that as long as children have mouths and their world contains objects that fit into those mouths, foreign body aspiration will occur. So vigilance is key.
For all the parents,
extremely important for us. Parents, particularly for those younger children less than 5 years, children less than 3 years, let's make sure that those toys don't have parts that they can easily swallow because that can just lead to aspiration. Let's make sure that they do not have any granules. So as Dr. Gbemi and I have said, please let us try to avoid giving children less than 3 years granules because it is all too easy. What are they chewing in? What's so exciting in the granite? If you must give them something granite, give them peanut butter, give them granite paste that you have ground rather than single whole granules. If you must give them a sweet, give them a lollipop, the one that is on the stick, that is not tiny and they can easily just swallow and go into other places. It's also important for us to advocate. I know a lot of the toys that we buy in Nigeria are not manufactured here in Nigeria, but still it's important that we read the labels of toys and buy age-appropriate toys for our children. Don't buy toys that are meant for 5-year-olds, for 3-year-olds, because they might contain parts that you might need to assemble. The 5-year-old knows that you have to assemble those parts, but the 3-year-old, everything is going into his mouth. The 6-month-old, everything, because it is the mouth that some children, a lot of children use to explore their world. The mouth is like their a tentacle. The tongue is like a tentacle. So once something gets into their mouth, they can tell. In short, children sometimes like as if they can actually tell how old the thing is, what country the thing was manufactured in, how many times the thing has been transferred. Children, it's like as if they have a magical power in their mouth because they're always putting things in their mouth. So let's make sure that as much as possible we avoid giving children who are less than 3 years small objects that they can easily swallow. Legislation is important. Let's make sure that we make sure that if we are manufacturing anything that's for children, they don't have parts that can be swallowed. Education, which is part of what we are doing. We need to tell parents that aspiration risk is real. One thing that I think children have aspirated that alarms me a lot is all these alkaline batteries. So these alkaline batteries, they're all those flat ones that are like discs, that are in watches, that are in certain toys. Now, those flat disc-like things, they are very small and it's very easy. You can't imagine how smart some children are. They will open the remote, take out the battery, and they imagine that, okay, let me lick it because it looks like a sweet, more or less, shiny sweet, and they want to lick it. And the next thing they swallow. The problem with those batteries is that what they do when they get into the airway is that they start to discharge. Have you ever seen a battery leak before? Parents, you've seen a battery leak before. All that horrible liquid that comes out of the battery when the battery has stayed inside a device for too long and then it has started to release some funny chemicals. That's how those chemicals are going to be released inside the child's trachea, and then it can create what we call a fistula between the trachea and the esophagus, so that when the child is eating normal food, can actually go into the trachea and the aspiration will continue. So it's a very severe condition. So as much as possible, let's pay attention to our remote controls. If it's possible, let us even plaster the remote control down extra to make sure that the child does not take out the battery, because I saw a child swallow a finger battery just not barely 2 weeks ago.
Wow.
If the child is lucky, the thing will go into their stomach and they will excrete it. But if it doesn't happen that way, then it will go into the airway and obstruct the airway. So I think in summary, aspiration is common That's the truth of the matter. Aspiration is common, but it is extremely preventable. Should aspiration occur, don't panic. Take the child to the nearest hospital, and let's make sure that we prevent aspiration by avoiding giving children who are less than 5 years any small parts that they can easily swallow. And extreme vigilance is extremely important so that we prevent aspiration from occurring in our children. With these few points of mine, I hope I've been able to convince you and not to confuse you that aspiration is real and preventable. Thank you so much.
Yeah, thank you so much, Dr. Renner. In fact, it's been quite an interesting presentation, and I like the way you kept it very lively and with all the. And I hope the parents that are watching us, you get the point, because this is one of those pediatric emergencies that we can actually prevent, that we can actually make sure it doesn't happen to our children. Unfortunately, we pediatricians, we see it a lot in children. So please, please, please listen to what Dr. Renner has said. And the video, the unshocking on what to do, how to release the foreign object the child has aspirated, will be live on Ask Pediatrician Facebook group. You can go and watch it. Just type "choking baby" or something. The video will pop up and you can watch it. So now is the time for you to ask questions. May I plead again? Please ask questions related to aspiration. Please don't ask questions generally. If you have general questions, please post it separately on the group and not as comments on this live. This is about pediatric emergencies and we're talking about aspiration. Dr. Renner is here to answer your questions. So I've seen a lot of questions that are not related, so I'm not going to put them up because of our time. So, but I will post those that I think are related. Okay, so Dr. Renner, Adeshewa is posting from Ugochukwu Bani. Say for children who find it difficult to swallow drugs, some children don't like medication. How about parents who compress their nostrils so that to force them to swallow the drugs? So what do you have to say to that? Because the mother just wants the child to take medication.
We had already mentioned that some parents do that. They compress the nose of the child and then they turn the child upside down. Yes, I agree, and I feel sorry for children because sometimes these medications can be so unpalatable, extremely bitter molecules. So options that you have, and I know a lot of parents have told them, okay, why don't you just put it inside some juice, put it inside some Fanta, and it might be a bit more palatable. What they say is that as soon as the child smells the drug, because the children they know that drug that is inside that Fanta that you're bringing, and they just throw their faces away. Well, what I would say is that sometimes distraction techniques are extremely valuable. Put on the child's favorite show. Get a very colorful toy. Get something that will distract the child as much as possible. And then try to offer the child. A mother told me that she had to sing for her child for about an hour. Sing and dance and then play around before the child eventually decided to take. I know a lot of mothers don't have time to sing for that long.
But, Dr. Ayo, I actually wrote a whole article on how to handle a medication refusing child. So what we're saying now is that force feeding or force giving medication is not the solution. You are trying to solve one problem, but you are going to create another. Please don't force feed, don't force children to take medication. We've mentioned different ways. I like the fact that Ayo has also mentioned about distraction. I always say, mother, start with don't pack too many drugs at once, just a little at a time. And if possible, if you can have the sweeter version of that medication, good. If it is tablets, hide it in your bar with lots of okra soup or ewedu soup. You wrap it around, the thing will just go down. Those are I'm a mother as well, so I know how we go about doing some of those things. So you can do that. Like I just said, you can add it to juice, you can add it to yogurt. Don't make it so obvious that you're adding anything. Sometimes the children won't know, but if you are doing it in their front, they will know. So those are the way. But sometimes if the child doesn't still take the medication, go back to your pediatrician. We know how to do. We give injections as well. We can give it into the vein. Sometimes that's the last option for some children. But force feeding is never an option. Forcing them, blocking their nose, because you are going to create more problem for the pediatrician than the one you were trying to solve. And this one is even more life-threatening. Thank you. Adeshewa. Okay, so Indukwe is asking that my 4-month-old baby normally choke on breast milk, and it comes through the nose. Dr. Aya, what do you have to say to that?
Choke. Okay, so choking on breast milk. Well, I really don't know if
I
the
think
child is
he
being
meant
directed.
reflux. Most babies have this reflux, and the milk is coming out from their nose. And so, what can she do about that?
So now, children will do something that we call possetting. So possetting is the situation in which they will
Okay.
bring up milk and this will come back up. So generally, a lot of them will stop eventually.
Yeah. Oh,
So
yeah. Nothing to
eventually
worry.
stop. Yes, to stop. However, I mean, if you find out that by 6 months it hasn't stopped, then you might need to visit your pediatrician for them to evaluate for what we call gastroesophageal reflux, which is a different condition entirely, and that might need some further evaluation. But generally, it will stop if if there's, and you need to look out for other things. So if the child is not having any abdominal distension, no watery poo poo, and the vomit is not green or the milk is not greenish in color, then we're okay. Then it's most likely that the child is just possetting. But if the child has any other thing, not gaining weight or generally having abdominal distension, then those are danger signs that it might be much more than just possetting.
Yeah. Okay. So just to also add, when mothers are breastfeeding, sometimes the babies are so hungry, they are in a rush, so they quickly grab and start to suck, and lots of air, lots. So sometimes in that process, the thing can come back. So what I normally do is I try and slow them down. You can remove the breast from their mouth and also bop them and all that. Then let them be calmer, swallowing and all that. So, like Dr. Renner said, if it's more than that, then you really need to see. Okay, Barry, thank you for your feedback. Okay, thank you, Adeshewa. Okay, Adeshewa is asking, I know a family that lost a 8-month-old girl due to choking on lollipop. It was grievous
Horrible.
for them. This is an eye-opener on how to handle it. But Dr. Redna, you were saying they should give lollipop. So somebody is saying somebody has actually, maybe the sweets came out from the steak or what? What do you think happened?
I think most likely the sweet probably came out from the stick, or maybe they offered her a piece from the
That is too
lollipop.
big.
That's too big, yes. And generally, I wouldn't even give an 8. I wouldn't even give a child under 1 year any sweets in the first place. I wouldn't give. Please, why would I give? I wouldn't give an infant a sweet, as much as possible, But if you must offer a sweet, don't offer any of those ones that are small. But now that you've given me an idea of this experience that you had, perhaps altogether,
We should stop lollipop as well.
as well. Just stop
8 months
lollipop as well.
old, really, please. And children must always be supervised. I mean, there's no way you can give an 8-month-old lollipop and you just walk away from that baby. These are things we don't do. And also, when we're feeding children, you have to be active feeding. Below the age of 2, 3, let's make sure we are there when they are feeding, because you don't leave them.
Exactly.
Because if you are there as a mom, you would have noticed it, you quickly intervene. And that also applies to cutting big chunks of meat for children. They can't swallow it. There's no point. And all these big chunks of agege bread. I've seen children also who have aspirated on such things. So please, if you want to give bread, use sliced bread, soak it well in the tea or but if possible, just avoid it altogether. All right. Thank you. Thank you, Aikulola. Thank you, Kainde. Ndukwe is asking another question. Good evening, doctor. My 4-month-old rubbed his eyes more than 40 times in 24 hours. Okay. Rub the eyes. Of course, this is not aspiration anyway. So, like we said, please ask us questions related to what we're discussing. But that sounds like a child who is having an allergic condition. So you may want to see your pediatrician. Okpayemi is saying, Kolawole, say thank you so much, Dr. Renner. Thank you so much, Okpay, for. Please ask your questions now. We still have about less than 30 minutes to go, and Dr. Renner is here to answer your question. So please ask your questions now. Thank you so much for joining us. Okay, while we're still waiting for more questions and to come up, I would just like to ask about fruits. I know you mentioned a lot about granules, but what about fruits? Fruits that have seed in them. All these agbalumo. I don't know what's the English name for that. I don't know.
I think agbalumo is called a cherry. It's called a cherry, but I do that.
Maybe your English cherry. I'm not sure whether it's your cherry. Okay, so how do you? Because that's another thing I think some children choke on. What do you recommend as fruits in terms of that?
So fruits give whole pieces of those fruits to children.
Seems like
You
we've
can
okay, you're back.
taking the orange segments out.
Yeah.
You take the seeds out of those orange segments and give the child the whole segments without even there's a skin that is around the segments. You should even take out that skin and then give them the pulp that contains the juice as much as possible. And this must be children older than 1 year. Children that are less than 1 year, please just blend it for them. Make it into a smoothie for them. They have no business going near anything that contains seeds. So fruits are important, they're essential, they're a good way of introducing children, moving them to complementary feeding, but make sure it's blended.
Okay. So you've had that. Parents, when you are giving apple, don't give them all those English, grape rather. When I say grape, those round grapes, please make sure you cut them into pieces. Children can choke on them. Okpa is saying thank you, Dr. Renner, very educative. Yeah, Victoria is saying thank you, Dr. Ebere is back and saying, is it advisable to mix drug in juice for children? Is it advisable to mix drugs in juice?
Okay. Now, the truth of the matter is that not all drugs are suitable to be mixed in juice, for children.
Okay.
It's important for you to read labels. It's important for you to read labels. Yeah. If you're in doubt, please ask your pharmacist or your pediatrician or your doctor and let them ask them, okay, is it possible for me to mix this drug inside a juice? Sometimes they would even say, don't mix it in any product, dairy products. So it would differ from drug to drug. So make sure that you read the label or ask your pharmacist or pediatrician.
Okay, thank you. Ndukwe, I'm just going to ask Dr. Renner to answer your question because you have been a very persistent listener. But like we said, please ask a question relevant to the topic. Okay, Ndukwe is asking, what do you have to say about adenoids? I don't even know what your question is about adenoids. Can you be a little more specific? What do you want to know about adenoids? Ndukwe, if you are listening, just kind of update that question. Okay. Okay. I think Okpa is telling us Agbalumo is African star apple. I don't know.
I've never heard that before. That's an interesting one. I'm learning on
Yeah, we're all learning today. Okay, so Kende Christiana is asking that my son used to eat fast and it chokes him. And I know it has to be a son. They are the one that will eat fast. They inhale the food. They don't eat it, they inhale.
Really?
Apologies to all the guys. Okay, so I have to slap him his back once in a while. So, Dr. Renner, what do you have to comment on that? She didn't have any specific question. I think she's just making a comment. Yeah.
Well, for children who eat extremely quickly, I think it's important for you to have family meal times. So what you want to, I don't know how old he is, but children, did she state how old he is?
Let me go down. She didn't say, can you tell us how old your son is? Just update it. Thank you. Okay, but just tell us generally, so maybe later we can.
Yes, I think generally it's important for us to form the eating patterns and habits of children. So in a modern society, I think a lot of us get extremely busy, such that we just slap the food in front of the child and then go to the kitchen to go and prepare other food, go and run our projects, go and do our things, and we don't monitor these children and see how quickly they're eating, how slowly they are eating, because all the child wants to do is just rush the food in a hurry, go back to the cartoon that he's watching, go and continue playing what he was playing before. But if we're having organized family meal times where we can observe the children and say, okay, this is the pace at which you must be eating. You are chewing too quickly, you are chewing too slowly, or just to monitor how they eat. I think it will go a long way. Now, for your child who is already eating quickly, I think what you need to do is that you need to actually sit down with him at meal times and then control his pace, so that you avoid, making him choke. I think it's extremely important. But organized family meal times, I think they help, even if it's just once a week. For the family, it serves bonding time and also serves to help you to teach children table manners, including speed of eating.
Okay, so you've had Dr. Renner. Eat with your children, and I always tell mothers, even apart from the fact that you can now slow down the child, it models good habits for the children. One of the reasons children don't eat is because they don't see their parents eat. Exactly, and so they begin to think that maybe that eating is it's a punishment for them per se, you know. But when they see everybody is eating and you are eating from the same family pots, like we pediatricians like to call it, the same pots household. That's the definition for the household. Those who eat from the same pots. So then they begin to understand that eating is it's a good thing. And then when they see the way mommy is eating slowly, they also learn it from you as well. So please make it something that you all do together. Thank you so much, Kehinde, for that question. Oladayo is asking, good evening. Please, doctor, whenever I give my baby vitamin C, she's always doing as if it wants to choke her. And when I tasted it too, it's Pamilori. Sorry, I didn't know the English word. Kindly advise. No, so what I'm getting from Oladayo, Debbie, you are saying that when you and your baby both take the same vitamin C, all of you feel as if the vitamin C is going the wrong pipe. What do you have to say to that, Dr. Renner?
Oh my goodness. Is it the white vitamin C or the yellow vitamin C? Because
I think it's
yellow
vitamin C syrup. I think, is it not so? She didn't specify, but I want to assume because she said baby, so let's assume.
So let me assume that it's vitamin C syrup or even drops. Oladayo, don't be taking your baby's vitamin C drops. So why are you taking your baby's vitamin C drops? Okay. That why she would choke on the vitamin C, I am not too sure.
I'm not sure as well.
Yes, you find out that various manufacturers will have various bases, from when I say base, I mean the substance that is used to convey.
Yeah.
Yes. So different people, for instance, if the vitamin C is not the only thing that is inside that vitamin C drops or syrup, there are sweeteners, there are liquids that help to make it more absorbable. That we call the bases. Now, those other substances might be, a little bit harsh, So it depends on the manufacturer. So maybe it's one of those other substances that you both are reacting to. But try and give your husband to take two to see if it's all.
What if the husband to ask apologies to the non-Yoruba speaking people? But basically,
their head, it goes like straight to their head. I can see if it just chokes them more or less.
But please, if you are taking something, generally speaking, that chokes your baby, then throw it away. That's just it. And Dr. Renner said, why are you even using the vitamin C in the first place? We don't recommend routine use of vitamin C. I know more Nigerian mothers love it so much. You see, you would do better giving your baby oranges, giving your baby fruits. That is natural vitamin C without all those additives that is causing the choking. Okay. People is saying thank you. Okay, Ruth is asking, my baby is 3 months and refused breast milk because of my job schedule. So I feed her on formula. Will it harm the baby? Well, this is not related to pediatric emergency, but since it is a pediatric show, let's just answer. So, Dr. Renner, what do you have to say to that?
My goodness. Okay, so what I would say is that I think it's possible. I have a feeling that you might have been giving formula even before now, because babies develop a taste for formula. Once that's what they started off with, sometimes in my experience, I might be wrong, but I find out that that's what they just want to continue with. So if at 3 months the baby is ready to refuse your breast milk, it means that in the first place she probably wasn't getting very much
breast milk
in the first place. Exactly. So what you will do now going forward is that breast milk keeps very well when it is frozen. So if you can get a breast pump and express as much. So when you were talking with Dr. Uche about children who, the newborns who were successfully exclusively breastfed till 6 months, I think that's something extremely laudable and it's extremely doable. I have a colleague who actually was able to take calls, and she expressed breast milk for her twins and was able to stop breast milk for up to 3 months for these children. Yes, she was expressing continuously. So frozen breast milk can actually keep for that long. So if you are determined, Ruti, Okwi, please express breast milk as often as possible so that even your flow doesn't dry up, and your child will be happy to accept it. So,
Okay. So if I may add that to that August is our breastfeeding week. So all of you can come back. And if you also go on Ask the Pediatrician Facebook group, we have a learning unit on breastfeeding. You will watch all those videos, how to make sure that your baby take breast milk. They are there already. Just go to Ask Pediatric Facebook group, go to units where there's menu. You will see photo, videos, files. You will see what is called units as well. So if you click on units, you will see the nutrition 101 course. There's one on breastfeeding. Read it. Most babies don't refuse breast milk, but that's not our focus, so we'll not go too far. But I think Dr. Renner has answered you quite all right.
You said, so I think her question was, now will it harm the baby? So no.
It will not harm the baby, but like if you have been listening to me on ATP Live, you will notice that all the time I've been talking about some of those childhood killer diseases. And every time I keep going back to breast milk as one of the preventive factors. So breast milk protects your baby against diarrhea, protect your baby against pneumonia. It is not just about food. So when you are giving formula, your baby is getting food. Your baby is not going to lose weight. Your baby is not going to die. It's not harmful to give formula. That's not what we're saying. But we're saying that your baby is indirectly more at risk of infections. Of infections and all that, because your baby is not getting the protection that breast milk provides, and that's basically what we're talking about. So don't worry, we're not trying to make you feel guilty or anything. We're just trying to tell you that the best, go for what is best. And what is best for your baby anywhere in the world is breast milk. Breast is best. But let's talk about that during breastfeeding week. Okay, Oluwatoyin Oshinoike is asking, my 2-year-old son does not chew his food. All these sounds. He swallows all food. Is this a concern? Okay, so Dr. Renner, over to you.
Meet me after this live broadcast for a meeting. We're having a meeting on this.
All the fathers and the sons that are not eating food.
So he does not chew his food and he swallows all his food. So this is a concern. Well, it still boils down to feeding times and how at feeding times. And so gentle reminders that chew your food before you swallow, will make him conscious of the fact that he should actually be chewing his food. I know at 2 years, they are very they can, especially boys, they don't hear anything. So you're just talking your own for yourself. So what you can do is that to an extent you can make the food softer than it would be for the rest of the family. I think sometimes parents need to be creative about how they solve some of these problems. So if you find out that you are giving him rice and the rice is coming out inside this poo-poo, maybe if you are like, so that's what a lot of people are worried about, that if he doesn't chew the food will come out whole.
Yeah.
But that being said, if you're worried about choking, then what you can do is that boil the rice for a little bit longer than you would for everybody else, so that it's softer. Okay. Make it a little bit softer than usual. Make the meat, or you make the beef or chicken, whatever it is, a bit softer than usual, so that even if he's going to wolf it all down, or how did you say? What did you say they do to the food, boys?
They inhale it. They don't chew. They just inhale. 5 seconds, it's all gone.
So if you're going to make sure that the food is as soft as possible, so that it's more easily digestible. Because truth be told, there is a reason why food needs to be chewed. Food needs to be chewed because it makes it more easily digestible. So if you have partially digested it before he's eating it by making it a bit softer, then I think half of the problem is solved. But I think it's more important for us to actually teach him how to chew his food properly before swallowing than for you to be making really soft food.
Thank you, Dr. Renner. Kehinde is updating a question that our boy is 1 year, 4 months old and is refusing family food except purine. Now he rejects it. I think Dr. Renner has answered your question. The same thing applies. We need to model for these children. You need to be there when they're eating and all that. Okay, Ndukwe is updating a question about my baby snore when sleeping or awake, especially when breastfeeding. And an ENT doctor said he has adenoids. So I'm sure the ENT doctor must have told you what is next. Usually for most babies, we watch them because the adenoids may resolve on its own as they grow older. If get bigger, then after all, it starts to shrink on its own. And if it shrinks, there's nothing to worry about. But if it is getting bigger or is getting infected, the child is having recurrent infections and all that, tonsillitis and all that, then they will they will recommend surgery and all that. But so I'm happy you've seen the ENT doctor. Please continue to follow up with the ENT doctor. Thank you. Okay, the person who asked about vitamin C said the syrup. Oladapo Debi. Okay, it's talking about syrup vitamin C. That is Sakpa Lori. I beg, throw that vitamin C syrup away. That's it. Try another brand.
Make your house straight into the lagoon.
Okay, Oladapo, just try another brand or just forget about it. Use natural source of vitamin C. Okay. Inkiri is asking, at what age can we start giving a child paracetamol tablets? At what age?
Okay. So I think that's another important point. Thank you for that question. Because medications in terms of tablets. So at what age do children transit from giving syrup to being
tablets?
You see, 5 years appears to be a cutoff. But if you want to be 100% safe, 7 years. 7 years is the safest time that you can say this child is ready for tablets. But if you have option of giving the child a syrup or as up to 5 years, up to 6 years, please give the syrup. It is only if the tablet form is not available, the syrup form is not available at all, then you can now offer the child tablets. But even at that, I would even say grind the tablets and dissolve it inside something, maybe juice, and then give to the child. So in other words, in some replace, a child less than 5 years, please don't give whole tablets to a child less than 5 years. Above 5 years, be cautious with giving tablets. Make sure that the tablets are not too large as to give them so much discomfort to try to swallow. If they are too large, break them into two and then grind them and then give. But any child less than 5 years, please avoid tablets as much as possible.
Okay, thank you so much. Yeah. Okay. Okay. And also, how long should you manage fever in a child of 1 year, 9 months before seeing a doctor? So that's a pediatric emergency question, which we already handled yesterday. I will answer it briefly to say, even the adverts on paracetamol and all those adverts you watch on TV tell you after 2 days, Abby, what did they say? After 2 or 3 days, if symptoms are not better, go see your doctor. But I'll tell mothers, go with your intuition. If the child is having very high fever, the paracetamol is not bringing down the fever, don't wait for 2 days. Go there that day or 24 hours you can go. But if you give paracetamol now, the fever it's not maybe like 38, 37, 37.5, 37.6, it's not so high. The child is playing, the child is otherwise well, there's no problem. You can just say, okay, let me watch for 2 days or so. But if a child is having 39, 40 degrees, you're giving paracetamol, the temperature is just staring at you, you are stepping, don't wait for 24 hours. Just go to the hospital. That is high fever, and high fever is still an emergency. So that's what I was saying, Kiro. If it is mild fever, you can watch, but if it is more, then you need to. Okay, I think Ruth is just updating that question. Ruth, we'll talk about breastfeeding another day. Let's just focus on the aspiration now. Yes. Okay, Oladayo is asking whether a baby can take orange. She's just 6 months old, and Oladayo, I think even the vitamin C you're given, you should be giving drops to a 6 month old. So if you are giving too much syrup, and drops is at 0.3 or 0.6, very tiny bit, less than a ml, something that we even just dissolve on the tongue, and that's the end of it. So, but your baby can take orange from 6 months, but it has to be orange. You extract the juice part and you dilute it, and you can give. But as much as possible, a little at a time. You also want to go and do that nutrition unit as well, so that you have clearer understanding. That's not our focus, so I will not want to dwell on that. Okay, Ruth is asking, can she restart breast milk? Dr. Renner, can she restart breast milk? She has stopped for some months, and does breast milk spoil while in the breast? Okay, yeah.
I know I've heard that thing a lot. That's standard. The breast milk has sour. I say, is it that the breast milk has turned to yogurt inside the breast? But I'm sure Dr. Gbemi has addressed this before.
We've done that before.
Breast milk does not sour or turn to yogurt or cheese inside your breast. So breast milk is inside the breast milk. Breast milk is manufactured on the spot. There's no such thing as there's some breast milk stored somewhere. It is as the baby is sucking, the breast milk is being manufactured. So it is always fresh. If the baby is not sucking, the breast is not being, manufactured. Breast milk is not being manufactured. So don't worry about the breast getting
sour. It doesn't get sour.
now. If you haven't been able to, you haven't breastfed for a few months, restarting lactation. Dr. Boyede, you might have to help me here.
Yeah, it's possible. Why not? It's possible. We can restart. So it is possible. You will need a lot of support because, like you are working because what really makes milk to flow, just like what Dr. Renner said, breast milk is produced on the spot. That's one of the beautiful things about breast milk. It is as the baby sucks, then the brain guesses that you need more breast milk, then it kicks off the production. So your baby needs to suck very well on that breast for the milk to come out. So it may be more frustrating than with the first beginning, but you can do it and it is possible. And I would say, don't stop your formula straight off. Don't stop it completely straight off. Continue the two, but make sure you try and put the baby to the breast as often as possible. And if you do that, then your breast will flow. And no matter how much, I mean, it's better than formula. The breast will always be better. So just try. But you can see the pediatrician, or you can see us behind the camera later, so that we can talk in detail.
So it's just to salute all the mothers out there who are breastfeeding or trying to breastfeed and working. 2 thumbs way up to you guys. You guys are the greatest of all time.
Yeah, our heroes. Yeah, a thumbs up to all the breastfeeding mothers. And just to say that for those of us that are pediatrician, because sometimes people ask us, we also exclusive breastfeed our babies, even when we are doing our yes. So I can say that, and I know a lot of my friends are exclusive breastfeed their babies. Yesterday, some of those that watches, you were seeing me giving thumbs up to Big Mommy. So you put your baby in the crèche even when we're working, then they will call you to come and breastfeed. You quickly run, go and breastfeed, and come back to work. So it's feasible. Doctor, what's her name? Dr. Irat Badmus has shared a story on the ASPIRATIONS Facebook group. She's a public health doctor, and she showed us how much of express breast milk she keeps, how she store express breast milk so that our baby will always have breast milk. And so all these things are possible. Okay. Gloria is asking that when my son, our time is running up, we won't be able to take too many questions again. Gloria is saying whenever our son takes egg, he usually vomits, and I stop it and all that. That may mean maybe allergic to the egg. If you want to try, you can try it again and see. But if he's allergic, don't keep giving him. There is not compulsory you should take egg. There are other sources of protein. If it's allergic, some people have egg allergy. That's honest. So don't give them if they are. But if you are not sure, maybe it's just that you didn't like it before and you want to try it again, and then you will say. I think this may be the last one of our last questions. Taiwo is saying my baby is 6 months and was on exclusive. Okay, can you please go to, if you prefer home diet, that's a good baby, perfect baby. Give him the home diet. Go and do nutrition 102 on complementary feeding on the group. And also, when can he start taking drugs? I tell you, why do you want to give your baby drugs? Baby was exclusive breastfed. Baby is on complementary feeding. Baby is fine. I always say, your baby don't need drugs. Why do you want to give the baby drugs? There's no need for drugs.
Want you to give them multivitamins.
Give no need for drugs. That's a very beautiful baby. It's not costing you any money. Just feed the baby. Baby likes some diet. He doesn't want you to go and be spending money buying store food and that 1,000 naira that you use to buy one tin of any of those cereals. You can eat for a whole month of that baby's food. I mean, your rice. I mean, oh, you have a beautiful baby and you are still complaining. This is my Nigerian mothers. God will help me. Okay. No. I'm not going to take that question anymore. Ask question related. I think I've given you enough room. You don't need to give. Oluwatoyin is asking about multivitamins. Please, can we release our questions to what is relevant to the topic? Because our time is up. Gloria is commending us about exclusive breastfeeding. That it's not easy, but she has done it, and I will give you. Thank you so much for breastfeeding, and don't worry. What is that, Dr. Renner?
Cereal.
Okay. All right. I think We are done. We are done. We are done. So last minute, we finish. I think I just want to thank Dr. Renner for giving us this time. I know it's not easy to catch any pediatrician at this time of the day. Thank you so much for being with us on Ask the Pediatrician Live.
Yeah, I hope you guys all learned something. I hope you guys came away with something. So thank you all very much.
Yes, we learned a lot. I'm sure mothers will tell us they've learned a lot. So thank you, Dr. Renner. It's been a pleasure having you on Ask the Pediatrician. God bless you. You're welcome. Okay, so bye, Dr. Renner. So thank you so much, everyone, for joining us on Ask the Pediatricians Live. So it is the day one of our conference. I hope you've learned a lot. If you are just joining late, this broadcast will be available as our watch party in the morning for those who mix the beginning part, or you just want to watch it over and over again. And tomorrow, don't forget to join us tomorrow as well. So I hope you've enjoyed it. Today we've had 3 speakers. I have Dr. Idika who talk to us about pediatric surgical emergencies, and then Dr. Uche Anene-Nzelu talked to us about emergencies in the newborn. And then we also have Dr. Renner, who just left now, talking to us about aspiration. I think it has been very interesting. We've learned so much, and going by the question, I can see people telling me, yes, that they've learned so much. They've learned so much. If you didn't take your question because they are not relevant, don't despair. You can go to the group and post your question. We have so many questions, but we want to post only those things that are relevant. I can see all your comments. Thank you so much for joining us. So tomorrow is going to be bigger. It's going to be better. We're going to be online tomorrow at 6 p.m. as well, 3 hours. We are going to have 3 speakers again. I'm going to have Dr. Buki Olatosi. All those of you that are asking the dental questions, please join us tomorrow. Dr. Buki will be here talking about pediatric dental emergencies. And then we're also going to have Dr. Oliba Moyo. She's going to talk about poisoning. Dr. Renner alluded to the fact that, when you give all these, put your kerosene in your Eva bottle and all children have spiritual sense. So we're going to take poisoning in children as a major topic, and that's what Dr. Oliba Moyo will be discussing tomorrow. And then finally, we're going to have Dr. Ogunlewe, and Ogunlewe is going to talk about CPR, because most of us, we don't know how anything can happen. God forbid the baby collapse. How do you start resuscitating the baby before the emergency team arrives, the ambulance arrives, and all that? So we're going to talk about all that tomorrow. So it is our Ask the Pediatrician anniversary week. This is our anniversary conference. We've started yesterday. I did a keynote address yesterday, talking about Ask the Pediatricians. And today we've started our online conference, and we've had the day one. We've had 3 wonderful speakers. We've answered lots of questions. And tomorrow we're going to have day 2 of the conference. And ATP Babies is coming up on Wednesday. Don't forget our ATP ATP Babies of the Year is going to be on HOP, and that will be on Wednesday. You can vote for the best baby. We're going to have the boys and the female category. So you're welcome. If you are going to be part of it, I'm sure you've submitted your application already. But for the rest of us, we are going to be voting and all that. So please make sure you join us for the ATP Babies of the Year on Wednesday. And then the quiz competition comes up on the quiz competition is going to come up on the Thursday, and it's going to be wonderful. We have lots of wonderful gifts, and so I will encourage you that you join us for the quiz competition on Thursdays. It's open to all the members of Ask the Pediatrician Facebook group. And then on Friday is going to be our recruitment campaign. So you want to be part of Ask the Pediatrician, you like what we do, and you want to be part of our team, you are welcome to join us on that on Friday, so that you can be part of our team. And then on Saturday is going to be an open house, but that one is going to be in the morning, and I will be here with some of our moderators, and you can ask me any question. That time I will no screen. Any question you post, whether medical, non-medical, about Ask the Pediatricians, any question you post whatsoever, make sure that we're going to answer them. And it's our anniversary week, so we want to have a feedback from you. So kindly go to our page, look for this poster talking about testimonial. We want you to tell us about Ask the Pediatrician. Pediatrician Foundation? How has we been impacting you? Have you learned from Ask the Pediatrician and things like that? So you can kindly go to our Facebook page, drop your story. If you want to do a short video, 1 to 2 minutes, you can do it and post and email it to us on askpediatrician@gmail.com. We may feature some of them during our feedback session and open house. And again, we've talked about if you want to be part of our team, you're going to be recruitment on Friday. And on Sunday, we're going to have our party and it's going to be a wonderful time. So as the Pediatricians Week is still ongoing, I am Gbemisola Boyede. I want to thank all of you who have been part of this broadcast today. And I want to say you can still watch all the live videos. You can send it to your friends, and tomorrow, don't forget to join us at 6 p.m. Try and share the video so that all your friends can also be part of what you are learning, so that we know together our mission and our passion on Ask the Pediatrician is to reduce child deaths globally, especially preventable causes of child death. So that is what we do, and that's what we keep on doing. I really want to thank all of you for joining us tonight, and till we see you tomorrow. This is Dr. Gbemi saying good night and have a wonderful evening. Bye.